Assalamu alaikum. I'm Dr. Maham Khalid, the co-director of the academic wing of Ventilators for Pakistan, and I welcome you all to the last session of our COVEB series, where we will be continuing with our topic from last night regarding the pediatric concerns related to COVID. This is part of the educational activities taken up by Ventilators for Pakistan. Ventilators for Pakistan started out as a humble effort by our founders, Dr. Sabah A.K. Akhtar and Dr. Rabil Tariq, during the COVID pandemic, which aimed to buy ventilators and medical equipment for the government hospitals of Pakistan. However, it soon evolved into a versatile, ambitious, and innovative movement being run by 75 plus young Pakistani professionals who want to make a difference in healthcare system of Pakistan. Each member brings their own vision and expertise to the table. Our current aim focuses on a three-tier model, namely primary, secondary, and tertiary healthcare. We're focusing on health awareness and education, which includes webinars and internship programs for young doctors, medical equipment procurement for underserved hospitals, and an innovative EICU project. Our EICU will fill the gaps in care required to save the most critical patients in Pakistan by incorporating technical innovation into healthcare. VFP has numerous teams working under its umbrella for the betterment of Pakistan. The HR team, headed by Dr. Kurat, works 24/7 to keep all the teams and volunteers organized. Dr. Amna Pirzada, Director Communication team, makes sure that VFP collaborates with different organizations to help Pakistan through any crisis. Our graphics team includes Ms. Maham Arkin and Ms. Tasmina, who help us make posts for our social media pages. Internship team headed by Dr. Varda is working day and night in collaboration with Shifa for You to train young doctors in EMR. Dr. Mavish Erkin and myself are the directors of education team we put in a lot of effort in organizing academic sessions to enlighten our healthcare workers with the latest in the medical field. Awareness team's director, Mr. Ali Fateh, along with his team, puts in a lot of effort to spread health-related awareness among the healthcare workers and the masses. Our content and research team, under the leadership of Dr. Abu Bakr, does research to make the latest content available. Dr. Mahanur Tariq, who is the director of social media team, makes sure that all the relevant posts are uploaded timely. Home management team is working under Dr. Danial and Dr. Amna to provide healthcare to the public at grassroots level. Our fundraising team, headed by Dr. Sana, is working to raise funds for essential medical emergency equipment to help Pakistan overcome any catastrophe. Our procurement and donation team helps with the procurement of equipment, hospital selection, and donation under the competent leadership of Dr. Fahad and Ms. Anila Sikandar. It has been a true honor to see the work being done by my colleagues at VFP. I thank you all for all of your unrelenting efforts. Now, without further ado, I would like to introduce my co-director and my co-host for the evening. She's the co-founder of Yarden, which has partnered with VFP in making these series possible. Dr. Mavish Erkin, over to you.
Thank you so much, Dr. Maham Khalid. Assalamu alaikum. It is an honor to co-host the COVEB educational series. Along with being the co-director of the academic wing for VFP, I'm also the co-founder for Yarden Foundation, and we partnered with VFP for these educational series in an attempt to make COVID-related knowledge available to everyone for free. Yarden family itself includes a group of 45 hardworking and extremely talented members, without whom the foundation wouldn't be where it is today. I would like to first mention some personalities without whom this web series would not be possible. Our patron-in-chief, Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, is a highly reputable and widely recognized expert in the field of medical sciences. He is an outstanding medical specialist with expertise in hepatogastroenterology. He is an excellent researcher, having authored over 500 publications and 4 books. His book titled Rational Therapeutics is an award-winning and well-renowned piece of work. He's a public health specialist with extensive work experience in serving the people of his country with dedication and professionalism. He served as a medical specialist in the armed forces in various roles, including Principal Army Medical College, DG Medicine, and as a Surgeon General, Pakistan Armed Forces. He has been awarded Hilal Imtiaz Military and has been honored with the title of Professor Emeritus. Thank you so much, sir, for accepting the role of Patron-in-Chief of the series. Our patron, Professor Dr. Samia Naimullah, is a well-known and prominent pediatrician and a teacher of teachers. She's a diplomat of American Board of Pediatrics and fellow of American Academy of Pediatrics. Dr. Samia joined Rawalpindi Medical College, now RMU, in 1988, where she served for 20 years, after which she worked at IIMC, Rifa University, as the HOD of Peds for 10 years. During this time, she was honored with Fellowship of College of Physicians and Surgeons in Pakistan, as well as BCPS Fellowship of Bangladesh College of Physicians and Surgeons. Professor Samia is a recipient of the President of Pakistan Gold Medal by Pakistan Pediatric Association for her outstanding contribution and services in pediatrics, education, and research, and has also been awarded Best University Teachers Award by HEC. She has been the president of Pakistan Pediatric Association for 2 years and a faculty member for CPSP. Thank you so much, ma'am, for accepting the role to be patron of this educational series. I would also like to take this opportunity to particularly thank Rawalpindi Medical University, which has accredited these educational series for all of us to enjoy. Thank you to the Vice Chancellor, Professor Dr. Mohammed Omar, and the medical education team of RMU, Professor Dr. Rai Mohammed Askar, Dr. Shazia Zeb, and Dr. Asma Shabir. Participants, kindly remember to comment your name along with your designation during the session, and in the end, do remember to fill out the feedback forms to mark your attendance. Now, with a lot of pressure, I would like to welcome our first speaker of the night, the esteemed Professor Dr. Mubin Rathore. Professor Rathore is a professor and associate chair at the Department of Pediatrics at University of Florida College of Medicine, Jacksonville, the chief of the Division of Pediatric Infectious Diseases and Immunology, and the founding director at the UF Center for HIV/AIDS Research, Education, and Service. He graduated from King Edward Medical College, Punjab University, Lahore, and from then on went to complete his residency in pediatrics at Children's Hospital Medical Center in USA. Professor Rathore completed his fellowship in pediatric infectious diseases from St. Louis University School of Medicine in St. Louis, USA, and another fellowship in pediatric infectious diseases from Washington University in USA. He started the first pediatric infectious diseases training program in Florida and continues to educate fellows locally and across the country. In 2017, he was elected vice chair of the American Academy of Pediatrics District X, which serves Florida, Georgia, Alabama, and Puerto Rico. In the same year, Professor Rathore was the first UF faculty member and only the second physician to be named the president of Leadership Jacksonville. Earlier that year, he had begun serving on the sub-board on pediatric infectious diseases for the American Board of Pediatrics, which certifies physicians in more than 20 specialties. In 2016, he was elected to the Florida Medical Association's Board of Governors, and in 2014, he became president of the Dual County Medical Society, an organization he was a part of for 26 years. In 2013, Professor Rathore was appointed to AAP's Committee on Infectious Diseases. The committee is responsible for the publication of the Red Book, regarded worldwide as the most authoritative reference in the management of infectious diseases in children. Professor Rathore holds special clinical interests in immunizations, pediatric HIV, infectious diseases in children. His special interests in research include immunizations, hospital epidemiology, infectious diseases in children, HIV/AIDS, and MRSA. Please allow me to welcome Professor Dr. Mubin Rathore to present his lecture.
Assalamu alaikum. I hope you can hear me.
Sir. Yes, sir, we can.
Share my screen now. No, that's not the screen I want to share. All right, this is the screen I wanted to share. Once again, assalamu alaikum. Thank you for your kind words. I think I was asked to speak about MISC only and not an update on COVID-19. I'm going to try to run through this fast because I believe I may only have 35 minutes or 30 minutes. I can't see anybody on my screen right now, so you have to say loud if I'm close to end of my time. In mid-December, hold on a second, guys. So in mid-December 2019, COVID-19 was identified as the cause of outbreak of respiratory illness in Wuhan in China. Since that time, COVID-19 has been officially declared a global pandemic and has rapidly spread worldwide. Only 8 months or 9 months ago now, and new information is coming out daily on this disease. There are really no experts on COVID-19. We all are learning about it as we go along. So remember the 6 E's. This is very important. There are no experts, right? Anybody who has a social media account is certainly an expert in COVID-19. There's also, which means that everyone is an expert. Experience with pandemics, epidemics, and outbreaks is critical when you're talking about COVID-19. And of course, understanding of epidemiology and experience in infectious disease and knowledge of infectious disease helps you to respond and understand the pandemic and manage the pandemic better. And so extrapolation from other infectious diseases based on our experience is what really helps us deal with COVID-19. So coming directly to MISC, so that is my, I guess, mea culpa on saying that I am not an expert in COVID-19 any more than anybody listening to this talk. So in late April of 2020, what was called multi-system inflammatory syndrome in children, MISC, actually the British call it something different, and I'll come to that, was potentially associated with COVID-19, and this was first described in Europe and Italy and UK. Since then, cases have been reported worldwide. In the US, all states have now reported MISC cases and some deaths. We realized very quickly that MISC actually mimics Kawasaki disease or toxic shock syndrome with a disease course that seems to suddenly worsen days after children seem to have initially recovered from a possible coronavirus infection. So this was very concerning to us. So this is a slide of timeline. I'm not going to go over this, but this is where the first alert was raised in the United Kingdom, and first reported death from this syndrome was in May 8, 2020, and by May 18th in the United States, CDC sent out an alert to all the providers. So let's talk about top 10s of MISC. This is, I think, very important. First of all, what's in a name? You know, we call it different thing in Europe, we call it different thing in UK, and I want to share with you a chart that may help. This is 5 different countries and their definition. I'm not sure if there's a definition of MISC in Pakistan or which one is being followed in Pakistan, but obviously in the United States, we follow CDC. Now, this is a very busy slide. I'm not going to go over with you on this, but my plea would be that we need to really have one definition. This is a new disease, a new syndrome, and if we don't have a unified definition, it's going to be very difficult to follow this worldwide. But you can see the age, for example, in the US, it's less than 21 years of age, and in the British, I think it's PSU is Pediatric Surveillance Unit, is less than 16, and the Royal College of Pediatrics and Child Health call it just a child. So you can see the age difference in these definitions. I can tell you, I was recently called by one of my adult infectious disease colleagues who had a 23-year-old who for life of me looked like MISC, but of course would not be counted as an MISC. So I think obviously we all understand that these age cutoffs are quite arbitrary. Then again, so look at this definition in CDC for fever of more than 38 degrees centigrade for more than 24 hours. And then if you look at what our Canadian colleagues, our neighbors to the north have done, is they've basically, true to a Canadian personality, have taken something that's in between what United States and the rest of the definitions were. What really surprises me, and gosh, I mean, I can't really understand this, that in the United Kingdom, they can't even agree between the two societies they have how to define MISC. Again, laboratory evaluation is important, and various places look at various things. And I think the fact that you have so many lab values in the United States probably is a testament to the fact that we do a lot of laboratory tests. And but others basically in elevation of acute phase reactants is the main thing here. Clinical features, again, they're also different from where you are. Again, the British can't seem to agree on most things, but they fortunately agree quite a bit on the clinical features. Its relation to Kawasaki disease, everybody says it could be similar to complete or incomplete Kawasaki disease, except for WHO, which does not comment on that. Toxic shock syndrome, the Canadian pediatric surveillance program is the only one that takes that into account. All of them say other diagnoses should be excluded. And about epidemiologic link, I think this is actually very important. In the US, it's a PCR positive or negative, but they could be serology positive, and there could also be an epi-link, meaning that the patient may have a PCR and serology negative, but within the last 4 weeks have a contact with somebody or with COVID-19 or in an area with high COVID-19. The Canadians and at least the Royal College say regardless, and WHO is like United States. So this is, I'm not going to go over this again with you, but this is really the criteria that we use in the US for individuals who we believe may have MIS-C. And I can tell you, even in Jacksonville, in our hospital, we have seen about 20 cases of MIS-C now. Some of those cases actually happened before April, when it was identified in UK, and in May when it was alerted in the United States. We just didn't know what it was, and when we got that information, we went back and we went, gosh, these kids look like they have MIS-C. So as they say, flower by any other name, you know, whatever you call it, I think it's important that we have a combined definition, a single definition that we can use across communities, across countries, around the world. So because we need to do a lot of research, we need to understand it, and if we have similar criteria, I think it would be nice. I think what I believe should happen is we should have minimal criteria for diagnosis of MIS-C, and other countries and WHO can add on their own. But things like age and how long the fever should be, that certainly can be agreed upon, just as we have agreed upon on Kawasaki disease. Number 3, remember, this is only an interim case definition, and that's what I guess I'm arguing for, that we need to have one case definition for MIS-C. We are probably, if this is a true entity, we are probably missing some cases of MIS-C. As we learned with Kawasaki, that we we had a definition of Kawasaki, then we realized that we are missing some cases, and now we have what's called incomplete Kawasaki, previously called atypical Kawasaki. So clearly there's an overlap with Kawasaki disease and toxic shock syndrome. You know, while the clinical findings do overlap several other symptoms, it's neither of those. I think that's the key thing. There could be a macrophage activation syndrome. Some people have even talked about hemophagocytic lymphocytosis. All of that remains to be seen. But there's certainly some sort of a cytokine release that happens. But regardless of what else we think, it seems to be a very distinct syndrome, and we're going to learn more about it as time passes. Symptoms of MIS-C, they varied symptom at presentation, and they can be distinct from, but they are distinct from acute and severe COVID-19 infection. Fever and GI symptoms seem to be more present consistently, and initially it was thought more than 65% of the patients presented with shock. We know that that is not true anymore, and the shock was more of could be cardiogenic, distributive, hypovolemic, or a combination. More and more we believe it is cardiogenic now. More than one organ system involvement, that's clearly still the case. And at that time we thought only a few children had respiratory symptoms. I will show you in a bit that there's probably 1/3 of the children have respiratory symptoms. And mechanical ventilation to support cardiac function or to facilitate procedures was the reason, not necessarily a pulmonary process. The lab evaluation, initial labs in patients notable for neutrophilia, lymphopenia, thrombocytosis, overexuberant immune profile, basically markedly elevated acute phase reactant, CRP, procalcitonin, D-dimers, ferritin, IL-6. Markers of cardiac injury also were present. And this is something we are not used to doing in kids. I've never done BNP or anything like that in kids, or troponin, but in this condition, dysfunction would included troponin, and BNP were elevated. Of course, concurrent infections are rare, and we really have to exclude them. Again, the detection of SARS-CoV-2 virus by PCR at presentation may be present, but it's really because it occurs 4 to 6 weeks later. What we're really looking for is serology, and also if there's an epidemiological link. Echocardiography is important. Echocardiographic findings are present early on, and often they demonstrate that there is impairment of the left ventricle function, but that could be variable. There are also presence of coronary artery dilatation and rarely coronary artery aneurysms. So serial echocardiography is necessary. We really don't know how far we need to follow this along. So we are, at least in the United States, we are cautiously following. This also becomes an issue with athletes, especially college athletes, where if they have had, maybe they have a longer term problem with the heart. And so there was a study from Ohio State where a number of the college football players, American football players, had some cardiac involvement, mostly of the muscle, not necessarily of the electrical part of it. So, so let's look at study population treatment and outcome. These are two initial studies on MISC, both published in New England Journal of Medicine. The study by Dufort was just kids in New York City, and by Feldstein was a study that included all the other children except those 99 who were included in the Dufort study. 80% of them had ICU admissions in either study. Ventilator was used in about 10 to 20% of them, and IVIG, intravenous immune globulin, was given in 70 to 80% of these kids. Because initially it was thought to be an immune modulator, so it was believed that this may be helpful, and we still do that. In our kids, or if we think that they have MISC, all of them will get IVIG. Steroid use has become more common now. Back and then, about half to 2/3 of children got steroids. Many of them got vasopressors. And also early on, we were probably identifying the sicker kids because, as you can see, that many of these kids were actually hospitalized. Fortunately, deaths were few. Almost more than 90% of the kids got echocardiogram, and 8 to 9% showed coronary aneurysms. Ventricular dysfunction was only reported in Feldstein studies present in 1/3, and they also reported abdominal imaging in 24% of the kids, and 77% of them had some abnormal findings. Our initial cases, we still keep on seeing these kids who come in, they look like they have appendicitis or an acute abdomen, and when we do further evaluation, it turns out that it is not appendicitis, not an acute abdomen, but it is actually MISC. So this is a very interesting study that CDC published back in July. They had 570 kids with MISC from 40 states, DC and New York City. The median age is about 8 years, which you will recognize a little bit older than what is when Kawasaki disease is seen. Now, in our experience, the age is a little bit even older. As you can see, the range is 2 weeks to 20 years. Of course, they only included individuals less than 21 years of age, so you won't have kids more than 20 years of age, and a little more than half were males. What is interesting is that Hispanics and non-Hispanic blacks had a high number of cases of this, almost 75%. Now, we know that the adult population was disproportionately impacted by COVID-19, the adult minority, people of color in the United States, and also in the UK, where it was Afro-Caribbeans and all people from the subcontinent were mostly affected. So it's not surprising that the children were also similarly disproportionately affected. The children who were affected were disproportionately those were people of color. In 86% of these patients, there were more than 4-organ or equal to 4-organ system involvement, and approximately 2/3, 66%, had no pre-existing underlying medical condition. So this, getting MISC, having a chronic underlying health condition does not predispose you to developing MISC. Most of the common signs and symptoms, abdominal pain was present in almost 62%. Vomiting, so GI symptoms are present in a large number of these kids, and that's what we had seen initially. More than half had skin rashes and diarrhea. low blood pressure was present in about half, and conjunctival injection was also present to almost half. Most patients had involvement of GI, as you can see, 90%. And cardiovascular was almost 87%. So, and 70% had skin involvement. Severe complications were primarily cardiac dysfunction, and this was seen in about 40%, and shock was seen in about 35%. Of those patients who had the echocardiogram, almost 23%, or about a quarter, had myocarditis. Coronary artery dilatation or aneurysm was present 18%, and acute injury was also common. Not surprisingly, about 64% were admitted to the PICU now, or in pediatric intensive care unit. Now we don't admit as many kids to the pediatric intensive care unit. We have recognized the condition. We know how to deal with it. So many of our kids actually don't go to the intensive care unit. They stay on the regular floor. We have had a few kids who ended up going to the ICU from the floor, but very few. And most of the kids, not most of the kids, some of the kids who were in the ICU just stayed there for a day or so, just stabilizing. They were shocked and they were transferred to the floor. The median length was stay at the hospital was not that long. It was only 5 days. Of these kids, 99%, more than 99% tested for SARS-CoV-2, and all were positive by RT-PCR or serology, one of the two tests. 46% only had positive serology, and a quarter had RT-PCR. Only one child did not have testing performed, but had an epidemiologic link that made it a diagnosis. 92% of the kids were treated. Remember, we don't even know how to treat it, but it looked like Kawasaki, thought to be an immune modulated disease. So IVIG was used in about 80%. About almost two-thirds received steroids. About 60% received antiplatelet medication. Little less than half received anticoagulation medication. Remember, we had learned by now that hypercoagulability is a big issue. About 42% were treated with vasoactive medications, and they also got other moleculars like anakinra and such, but that was a small number. And there were 10 deaths in this study, about 2%, similar to what was seen before. What CDC did is what they call the latent class analysis, and this was very interesting. I'm not going to go over this in any detail, but to tell you, about 1/3 had multi-organ involvement, where they had more than 6 organs were involved in about half. Most commonly involved, not surprising, was CAVS and gastrointestinal, and a significantly high prevalence of abdominal pain, shock, and myocarditis in this group, class 1. Lymphopenia was present, including elevated acute phase reactants, troponin, and BNP, and pro-BNP, and this was statistically significant when compared to the non-MISC, compared to the other 3 groups. Almost 100%, 98% were positive for serology, with or without positive PCR. Remember, you don't really need a positive PCR to make this diagnosis. And there's also some concern that the positive PCR probably indicates presence of an RNA viral particle and not evidence of acute infection. This condition closely remembered with this group of MIC patients without overlap with acute COVID-19 or Kawasaki disease. The class 2 was primarily almost 1/3 respiratory involvement, pneumonia, ARDS, cough, shortness of breath. The rate of RT-PCR positivity was 84%, and it was significantly higher than that for class 1. As you noted in class 1, you can see that the PCR was not as common as in class 2. And in class 2 also, the case fatality rate was highest among all 3 classes, and this was statistically significant. And that may have to do with the fact that they had respiratory problems. They were probably intubated and just deteriorated that way. Class 3, again, had about 1/3 of the patients. They were the median age was 6 years, which was lower than the age seen in the other 2 classes, and that was statistically significant. Highest prevalence of rash and mucocutaneous presentation in this class. The coronary artery aneurysm and dilatation were present in about 18%, which was more than what you were seen in class 2, but less than in class 1, but pretty similar amongst these 3 classes. The more commonly met criteria of complete Kawasaki disease when compared to class 1 and class 2, but this difference was not statistically significant. They had lowest prevalence of underlying medical condition or organ systems involved, complications and marker of inflammation and cardiac damage. Even though they looked like Kawasaki, the heart damage was not that common. About 2/3 was positive with serology, and 1/3 of them had a positive serology and PCR. So I created this colorful table for you to just show you the classes. So there's class 1 is what I will call shocky MISC. Class 2 is respiratory illness MISC, and class 3 is Kawasaki disease-like MISC. Presentations are different. Class 1 has more myocarditis, more abdominal involvement, and increased levels of acute phase reactants. MISC respiratory is more respiratory, as the name shows, and of course Kawasaki disease-like had more Kawasaki-like symptoms. Serology was present in positive in 98% of those in class 1, but only 63% in class 3. In PCR was 84% positive. That's why I think you have to do both serology and PCR. Coronary artery aneurysm were present in all 3, and complete Kawasaki disease diagnosis could be made in about very similar, but highest in class 3. So the clinical spectrum of COVID-19 and COVID-19 associated multisystem inflammatory syndrome in children is quite varied, and you can have, in most children, COVID-19 causes no or only mild symptoms. So remember that most kids are fine. They will have a febrile inflammation state associated with COVID-19. They may have a Kawasaki disease-like syndrome, and of course, a small group will have MISC associated with COVID-19. There's a lot of words on this. I'm not going to go over it, but I just wanted to make sure I explain the spectrum of this COVID-19 disease. So we really don't know what the optimal management is. Even though most of the kids got IVIG, a lot of them got steroids, almost everybody got something, we really don't know what the optimal management is. We know that we have to treat any shock that may be present. We have to reverse the shock, just like a standard medical care. If there are respiratory problems, we have to deal with the respiratory issues, including if you have to intubate them. We give all of them IVIG. Other immune modulators, corticosteroids, anakinra, infliximab, and less frequently tocilizumab have been used. It has to be managed multidisciplinary with ID, intensive care, rheumatology, cardiology, hematology, to develop the best individualized management plan. We certainly need more research in understanding the immunopathogenesis of MISC, and this is the only way we are going to understand how to recognize it, what is the real spectrum of it, how we treat it. And that was my earlier plea, that it is important to have one definition. We have so many definitions right now. I'll be very interested to see what definition you are using in Pakistan. And I think there are research efforts ongoing, and clinicians are encouraged to contribute to the advancement of science by participating in registries. That is, anybody can participate. It is free, but they don't pay you for that work. I think this would be a good project for some budding pediatrician who wants to do his FCPS project to look at this in Pakistan as something. So I think this is true for COVID-19 and MISC. We know what we know, and we know that we don't know a lot. I think this is important. There are too many unknowns. I lead the effort to response to COVID-19 in Jacksonville, Florida, because I'm the chair of the Infection Prevention and Control Committee for Baptist Health System, both Children's Hospital and the Five Baptist Hospital, but also my involvement with the University of Florida. We are involved in vaccine studies, monoclonal antibody studies, lots of studies, treatment studies. There's a lot that needs to be learned. Similarly, for MISC, we need to be thoughtful, systematic study of the disease entity and ongoing, because I believe that we may be missing some cases. And I think it's important, not only do we understand what is the clinical spectrum, how you diagnose it, what laboratory evaluation you need, especially in the under-resourced parts of the world, and what we need to do to manage these patients other than symptomatic treatment. So I always show this slide. This is advice from our medical school professor of surgery, late Professor Zafar Haider. I heard him say this for the first time. He says, half of what we know in medicine today is wrong. We just don't know which half. So I think having humility and saying, I don't know is fine. There's nothing wrong in saying, I don't know, let's learn together. One of the things that when I teach students every week, I tell them that we will learn together. Students ask the best questions. And if I don't know the answer, I'll say, I don't know the answer, let's go look it up. So it keeps me on my toes. So I think, I know there's an expectation that our seniors, our professors, they will know the answers. And I'll tell you this, you can take this message home. If you have a professor who knows that who thinks that one person knows everything, they are probably the dumbest person then. We need to accept that nobody knows everything. We are all students. That's why it's called practice of medicine. We practice medicine with all our professional careers. Okay, so just keep that in mind. I believe that may be my last slide. Oh, there are lots of algorithms. I'm not going to go over this. How much time do I have? Can somebody tell me, or am I past my time? Because I can't see you, so you have to speak up.
No, sir. You have time. Don't worry.
How much time do I have?
You can take another 10 minutes if you would like.
Okay.
5, 10 minutes, as long as you want.
Okay, so I'm going to go over this. I think what I would say is it will be important. Pakistan Pediatric Association should probably get together and develop an algorithm. You may already have, and I don't know. Then if you have, please share it with me. My friend named Zafar in Lahore he's my classmate. He keeps me updated on things, but we have not had a chat on this. By the way, Dr. Sumayya's younger brother Tayyib is a dear friend of mine. I did not know that until I heard of, and I'm so sorry. My condolences to Dr. Sumayya for passing of her husband. Inna lillahi wa inna rajiun. I'm so sorry to hear that. But anyways, so I have it's a small world. Tayyib and I go a long way. We've been friends for 40 years. Anyway, so what I was going to say is that we need to have an algorithm, especially in those diseases that we don't know what causes them, what is the exact diagnosis, there's not a test you can do diagnose the disease entity. You don't know how to manage it. It's helpful to have some pathway, some clinical pathway. I show you this. It's a very busy slide, and I show you this to tell you not to confuse the issue. I think I have some. Yeah. So I think first important thing is how to diagnose it. We have to do that. I know we have criteria, but I think what helps, I don't know if you are familiar with what's called the checklist culture. None of us are going to remember. I sit on the board of American Board of Pediatrics, and the thing I always stress with that is that of sub-board of infectious diseases, we should not be testing people's memory. Unfortunately, I think all of us would agree, when I was a medical student, our memory was being tested, not necessarily our concepts, our understanding. I remember I had memorized by Rata the Krebs cycle. I don't know if I've ever used Krebs cycle in my whole career since after taking the exam. I don't even know what it is anymore. So that's a classic example where we are asked to remember things which is useless, and especially in this day and age when you can in 2 minutes get on your smartphone and figure out exactly what we need to have in the concept. So I think having this sort of a thing is helpful. Have some sort of checklist. Does it meet criteria or not? So that's the first thing, clinical and historical features. Then there is the ED evaluation of possible MIC. This is in the emergency room. Now, it may be different. Your patients, I don't know if they get seen in the casualty department or not, but most of our kids end up in the emergency department. So your history, physical, COVID exposure, or positive diagnostic test. This becomes critical because if there is epidemiological link, you should be testing for serology and so then assess the inflammation, assess the evidence of shock. Of course, urgently, that's the key thing, especially since we don't know how to really treat it. If they are in shock, we need to stabilize them, give them fluids or whatever. If they are stable, then evaluation for possible MISC in a stable patient, fever, history, and all of those things you will have to do. Suspected MISC with shock, that's a different thing. You have to manage it differently. There may be a Kawasaki pathway here also. Initial laboratory test. Now, I think in under-resourced parts of the world where we have limited resources, I'm not sure we have to do all of them, but I would say we probably have to do at least some acute phase reactant. And other things that you will do routinely in managing a shocky patient. Other testing, lab and physical exam. If lab and physical exam are reassuring, you can discharge, they tolerate oral reassuring physical examination, but must be a follow-up within 24 to 48 hours. Labs or exam concerning but inconsistent with MISC, admit to inpatient and evaluate for other things. Consider whatever the differential diagnosis is. If CRP is elevated, sedate is elevated, lymphopenia, thrombocytopenia, low sodium, abnormal creatinine or age, consider further evaluation. You need to do all the other tests that are specific, we now know, for MISC. And cardiology needs to be involved. They are very key in this. Your intensivists and your cardiologists are extremely key. People like me, infectious disease docs, we can come help, we stay up to date on treatment, management, those things. But these are the guys who are going to do the initial important management, and cardiologists especially, who need to do a long-term follow-up. All right, so the other side, so this was one side. The other side is sepsis pathway. Use if they look shocky and septic, you do want to exclude sepsis and do other testing, fluid resuscitation, vasopresses, antibiotics, etc., and then admit to the ICU. So that was one pathway. There's also a pathway by the American College of Rheumatology, very similar. Of course, they are rheumatologists, so they are talking about, like infectious disease docs, more about not the acute management, but here. Does the child have all the following? If they meet the criteria, continue standard care, monitor MISC. I'm sorry, if they don't have the criteria, you do this. If they do have the criteria, if shock or unclear etiology, if it is yes, of course, you have to do the complete full diagnostic evaluation for shock that I just went through. If not present, then consider child under investigation for MISC. Many of our kids are really following in this category, not in this category, but few do. Have other causes that could explain the presentation being considered for evaluation, because it is a diagnosis of exclusion still. You want to make sure you don't miss a kid who has meningococcal or meningococcemia or another sepsis with another organism, or has Kawasaki disease or has cardiomyopathy unrelated to MISC, maybe enterococcal or something. And so there are so many other things you want to exclude them. And then, of course, it goes through all these evaluations, which I talked about earlier also. And again, the diagnostic pathway, of course, is going to differ depending on what your specialty is. Outpatient evaluation of MISC may be appropriate for well-appearing children with stable vital signs and reassuring physical exam, provided close clinical follow-up can be assured. I'm not going to tell how you do it in Pakistan. My biggest misfortune is that I left Pakistan right after taking my exams and actually found out about my results when I was already in the United States. I have not actually practiced in Pakistan. And when I was there in Children's Hospital in Pindon, Islamabad in '96, establishing under a grant from the United Nations, establishing I think Dr. Mumtaz was a young faculty at that time, trying to establish the infection prevention and control program. I very quickly realized what a misfit I was. And I really lamented that because, but subsequent to that, I've spent a lot of time in Lahore with Dr. Muaz and Dr. Naeem Zafar working on some of their projects, so I've learned a lot. But again, you know best how to manage it in your situation. Consider admission if there are abnormal vital signs. That's what we'll always do. Respiratory distress of any severity, neurological deficit, renal or hepatic problems, really elevated inflammatory markers, or if there's abnormality of the heart, that's critical. I think I already mentioned that shock, significant respiratory syndrome, neurologic changes, they have to require further workup. These are some, I'm going to quickly go through these. Again, these are, a lot of these things you have to really understand based on the various criteria. These are published criteria. We in Jackson, we have our own clinical pathway. When the patient comes to the emergency department, what they need to do when they're transferred, where they should be transferred, what to do when they're transferred, who to consult. And it works reasonably well. In the 20 patients we have seen since March, it has worked really well. We have not had any death, but we had some very sick kids in this situation. That's my last slide. I will stop there, and I am delighted to answer any questions that you may have for me. Thank you very much.
Thank you so much, sir. Thank you. It was quite an informative session. With your permission, I would like to ask a few questions from the participants.
Sure.
Our first question: do you see a point in trending the acute phase reactants? How often should they be treated?
Well,
How
I
often
think
should they be trended? Sorry.
this is the reason for doing the acute phase reactants is because it meets the diagnostic criteria. I think you can do the same thing by just examining the patient, evaluating the patient, and see if they're getting better. I think if you have so we don't use acute phase reactants in MISC like we would use, let's say, in osteomyelitis, septic arthritis, where we are looking them as a prognostic thing. If the patient is clinically getting worse and you do the acute phase reactants and they elevate it, what does that help you in? Nothing. It's waste of resources. Now, I'm going to tell you that in the US, we do too many lab tests and we do acute phase reactants here also a lot. But I always tell the students and the trainees that before you do a test, you should know what you would do if the test is positive and what you would do if the test is negative. If you don't know answers to that question, go look for the answer first. And I think, so this is important. Not doing tests for the sake of testing, that will not be helpful.
Thank you so much, sir. Our second question, what do you think is the pathophysiology behind the presentation? Do you think there is a genetic predisposition?
So, we have to be very careful. I would refer you all to read a book by Angela Sayani. It's called Superior. I think we need to be extremely careful that we do not attribute things to genetic causes. I don't know. Let's start there. I don't know if it is or it is not. If there's genetic predisposition? But I would think not. I think the fact that we see it predominantly in what I would call the people of color, brown people, and the African Americans, that's because of the access to healthcare. The disparities and inequities of healthcare have put them at increased risk. We are going to learn more about it over time. But as we sit here today, I do not believe it has got a genetic basis, and I don't think we should assume that it has a genetic basis. If there's a long history of assuming that things are genetically related, in India and in pre-partition and in the United States, lots of things were attributed to blacks during slavery and after that, and that is really to advance a racist agenda and a discriminatory agenda. So we need to be extremely careful to attribute things to genetics. We should study that. I'm not saying we should not, but we should not assume that.
Okay, thank you so much, sir. We have another question. What if parents are not giving the right history of COVID patients in the immediate family?
Well, in pediatrics, we are always, we have to deal with the parents, they have to tell the history. So if they are not giving the right history, of course, you can test the patient. If the patient is, because remember, the epi-link is one part of it. You can also do serology and you can do RT-PCR. But I think, again, if the patient meets the criteria, but you don't have that part, because we don't know what really causes it, the management is probably going to be similar. So, but if you think it's Kawasaki disease, you're going to give IVIG and you'll give aspirin. If you think it's toxic shock syndrome, you're probably going to give fluids and you're going to use clindamycin or some other antibiotic, but usually clindamycin. So I think, that's the thing we live with as pediatricians. We have to count and depend on our family and parents and guardians to give us the history. And I had a case a few years ago where a kid had TB, and there's a kid who had the kid was born and raised in the United States, had immigrated from Burma or Myanmar, and we specifically asked history of TB, and they said no history, nobody has a TB. We're going to continue to evaluate until we found that the patient actually had TB, had CNS TB. Turns out the father had TB and had a very severe TB, and he was living in the household, of course, and so they didn't tell us that because in Myanmar, TB has a big stigma, so they're not going to tell you that. So I mean, those sort of things happen in lots of other diseases also.
Thank you so much, sir. We have our last question. Is there any use of interleukin-6 inhibitors?
Well, IL-6 inhibitors have been used. To say if there's a use or not use, it's hard to say. If you looked at the data that I presented from several of the studies, IL-6 inhibitors have been used as an area of very great interest in research, and we are going to continue to go look at it. And it's also possible, just as I gave you the 3 classes that CDC developed by the later class analysis, that there may be different types of MISC disease. And some may have one type of thing more common, and some others, the pathophysiological roots may be slightly different. So in a subgroup of these patients, IL-6 inhibitors may be of benefit. We don't know that, and I think that's why we need the study. That's why we need a good definition. And that's extremely important. Let me ask you a question. Does the Pakistan Pediatric, or anybody can answer that if you don't know the answer, has the Pakistan Pediatric Association come up with a clinical pathway or a definition or criteria to diagnose? If not, are they using some other country's criteria or WHO criteria? If you know the answer, maybe somebody in the audience can answer that.
Maybe someone from the audience could answer that. That's actually a very good question. And we do have another a participant asking that as well. What's the treatment for a COVID positive child, the standard treatment?
Oh, COVID positive, not MISC, right? You're talking about treatment for COVID positive child. There is no approved treatment. Remdesivir, you can use in a compassionate protocol. We are actually about to embark on a study on using remdesivir for children. Fortunately, most kids with COVID-19 infection do not get very ill. But I think the only thing we have available is remdesivir, and we have used it in a couple of patients. Remdesivir, but that's the only approved therapy. The other things are still bogus: hydroxychloroquine, vitamin D. None of them are proven. If you believe enough in something, you can anything can be helpful as a placebo. But really, there's no scientific evidence. Now, some of those things may be helpful, but as there's no scientific evidence that they are helpful. Even remdesivir, there's no studies in children. We are extrapolating from studies in adults that they are helpful. That they may be helpful.
Thank you so much, sir. We do actually have Rabil Tariq online, and she said that they do have a study, Pakistan does, and they have published it in Lancet.
No, Rabil, I can answer Rabil.
That answers your question.
But no, the question was, what criteria are we using in Pakistan to diagnose? Are we using the WHO criteria, the UK criteria? That's really funny because those two organizations cannot agree between themselves. Are we using, which criteria are we using, and have we developed a clinical pathway? I think that would be great service. Have we developed a clinical pathway, how to diagnose and manage based on the local resources available, MISC?
Okay. I actually have the study open right in front of me. It's
I'm familiar with the study, but what I'm really asking is for practicing pediatricians. That's what you need. And the study is great, but we really need to know the study probably used, I can't remember, but I think they used some criteria. I think they used WHO criteria, but I could be wrong.
Initially.
But
initially they did.
Go ahead, Mahawash.
No, it's okay, sir. I was just saying initially they did use WHO, but currently I'm not exactly sure what they're following.
Yeah, how many places? If you are in Handu, can you do a CRP there if you have a kid? That's the sort of thing we need to, you may be able to do it at PINS or Rawalpindi Medical University or Army Medical College or those places. But if you are in north of Kalam, can you do it there? Can you do it in interior of Sindh? Can you do it Kot Addu? I don't know. I think we need to have something that is helpful to the practicing physicians.
Okay, thank you, sir. I think Professor Rai will be able to answer that.
Mahavish, in the chat box there says, that's from Maham, that Professor Rai will be able to answer it. Is Professor Rai on the call?
He's also backstage, yes.
No, he's here with Mahavish.
He's right here, yes.
So maybe he can answer.
Professor Rai, are you with us?
Yes. What's the question?
Do we have what criteria for diagnosis of MISC are we following in Pakistan? And is there a clinical pathway? Has the Pakistan Pediatric Association developed their own criteria based on local resources and needs and the clinical pathways for that?
Yes, Pakistan Pediatric Association, along with the help of WHO and UNICEF, has made, clear guidelines for the management of COVID-19 as well as MISC in children. So we have trained many, you see, doctors and in our setup, and as well as in the periphery, and we are using that. You see, that's basically based on WHO guidelines.
Yeah. Well, my question was, if you are in Hangu, or you are in Kot Addu, can you do CRP there? So a guideline would not be very helpful if you can do it.
Well, these guidelines are very simple.
Good.
And on clinical basis, and sometimes even say PCR is not available everywhere.
Right.
So on clinical grounds, definition is very you see basic, and it's based on clinicals.
Good.
So that's very basic, you see, management and clinical. Moreover, as you already said, there is no specific drug available for COVID-19 or this multi-system inflammatory disease in children. So that's again symptomatic. If IVIG is, yes, specific, but there is no other drug available.
Yeah. Well, I hope you have got my student par excellence. Ajaz Khan is, in fact, PhD close to you guys. I hope you guys have engaged him. He's a very smart kid. He was our resident trainee, and he can probably get together all the PhD guys in Pakistan. I think Yasser is in Aga Khan, and they can all get together. And I'm sure there are others I don't know about. And I think Hanif is also in Karachi now. He was our fellow. So I think getting a group together and establishing, Dr. Sajid Makbul, I know, has great interest, our teacher in ID. So I think getting a group together to establish those, meeting the local needs away from even WHO, I think is very important. I think we need to have our own homegrown criteria, homegrown management, because it addresses our needs. I think that's what we do in Canada and in UK and in the United States, frankly, may not be applicable. So, I mean, IVIG is extremely expensive. I'm not sure how many people can afford it. So, well, thank you very much for the opportunity, Dr. Rai. I appreciate you coming in and enlightening us on this.
Thank you so much, Professor Rai. Professor Mubin, with your permission, I would like to conclude the question and answer session.
Thank you so much. Thank you for the opportunity. It's a great opportunity, and I appreciate you giving me the opportunity to speak with this August group. I appreciate it.
Sir, the honor was ours. Thank you so much for sharing such valuable information and for discussing IMSC. And thank you for sharing your experience with us. It was honestly, truly an honor to have you on board with us.
Thank you.
Thank you so much, sir. Dr. Maham, I would like to hand this over to you now.
Thank you, Mavish. I would now like to introduce our second speaker for tonight. He's already here with us. Professor Rai Muhammad Asghar is a graduate of Nishtar Medical College, Multan. He did his MCPS and FCPS from CPSP Karachi. Professor Rai Asghar is professor and head of departments of pediatrics at Rawalpindi Medical University, and he's also the head of the pediatric department at BBH and Holy Family. He's one of the most senior child specialists in the twin cities of Rawalpindi and Islamabad, and he has passion for teaching and training of under and postgraduate medical students. And therefore, he holds the position of Director of the Department of Medical Education and Board Member of Advanced Studies at Rawalpindi Medical University. He's also the Medical Director at Benazir Bhutto Hospital. He's a supervisor for FCPS and MD Pediatrics. He's also the proud president of the Pakistan Pediatric Association, and he has special interest in research and has many publications under his belt. I'm pleased to welcome Professor Rai to share his immense knowledge and experience with us tonight. Professor Saab, over to you.
Thank you very much for a kind introduction. I am really glad and thankful to you. And secondly, I must congratulate the organizer, especially Professor Samia Naimullah and Dr. Mahavesh, Dr. Maham, Dr. Sabah, and others for organizing these educational activities. And I must congratulate, you see, all of you. So it's wonderful, you see, activities, and lot of, I hope, hundreds of doctors must have been trained, and they have been educated. And ultimately, you see, benefit will go to the patients. So thank you very much. So my task was epidemiology of COVID-19 in children. So I am having a small presentation. Next slide, please. Well, regarding COVID-19, we know during the last 8 or 9 months, we know a lot of things regarding COVID-19, and a lot of literature is coming up. And the major, you see, journals, they are accepting only, you see, articles on COVID-19, and they are refusing other articles. And from day-to-day basis, we are getting more knowledge and more information. Rather, R to R, you see, knowledge information is increasing, and the data is also being changed from R's to R. But still, I believe, as I said, we know a lot of things regarding this disease. But still, I think we know little about this disease, because this disease is this is a new disease, and still it's in an evolving phase, and we will not never know what will happen, you see, in next few months or next few years. And COVID-19 has changed the whole world, and it has affected each and every, you see, aspect of our life. So setting this, COVID-19 is highly infectious disease, and as you know, it's caused by severe acute respiratory syndrome coronavirus 2. So SARS-CoV-2, basically SARS-CoV-2 is the virus which leads to COVID-19. COVID-19 is the disease. Outbreak started in Wuhan, China, in the end of December, while WHO on 30th January 2020 declared global health emergency. Till to date, although a lot of work is being done on vaccines, and but vaccine in the market is still not available. Maybe at the end of this year, or maybe at the beginning of next year, we will have vaccine available for our children and adults. A lot of work is being done, and phase 2 and phase 3 trials are being done on vaccines. And secondly, there is no specific treatment yet available, although a lot of research has been done on various drugs, and various drugs are being used for COVID-19, but still there is no specific, you see, medicine available. In pediatrics, again, in children, again, apart from, you see, steroids or symptomatic treatment, we are not using any specific medication in pediatrics. Next, please. Well, coronavirus is enveloped positive single stranded large RNA virus, and people believe that it's endemic in animals, and probably it jumped from animals to humans, and now from human to human transmission is there. And because there are projections on the surface resembling solar corona, and corona is basically crown, so that's why it's called coronavirus. And it's spread through droplets or contact with an infected person, and directly patient is infected from other person, but indirectly by touching contaminated surfaces. Here I will mention that if you see observe, you see protocol or SOPs, then you can save yourself. Because in our, you see, Rawalpindi Medical University and Allied Hospital, especially those doctors who are working in COVID, you see, ICU, and nurses, along with doctors and nursing and other paramedics, all were safe, because they were observing, you see, recommended SOPs. And the doctors who were infected, they infected outside. So if you observe, you see, standard guidelines and SOP, and then you are definitely, you see, protected. Otherwise, this disease is highly infectious, and just one shake hand is enough to get the, you see, this disease. Or if you are talking with a patient, you never know that that patient might be having, you see, that disease, because asymptomatic cases are more common than to the symptomatic cases. Next, please. Well, there is no clear-cut evidence that disease is transmissible to the fetus through intrauterine transmission. Although in certain studies in certain neonates, this virus was positive, but there is no clear evidence yet that it's intrauterine transmission or not. Well, the mean incubation period in children is 5 days and ranging from 0 to 24 days. And there is asymptomatic, transmission, and majority of the children, they are asymptomatic and can transmit to all age groups from, neonate till elder peoples. Next, please. Well, children mostly they get the disease from their family members, and because in this epidemic, and schools were also closed, and children were at home, and if any person is infected, that can infect children. So children they get from usually their parents or other person in the household, and usually there is index adult patient available in the family who infects the children. Uh, well, children are not strong source of transmission as adult, but this is not yet confirmed. And some people say that no, children can transmit the disease, and children are having less severe disease, and they are silent, having silent disease, and they can transmit disease to the other persons. And viral load in nasopharynx is same or sometimes higher than in adults, although symptoms and severity is less, but the viral load is there. Next, please. Well, COVID-19's incidence in children is less. It's 2%. I will tell you later in later slides. What's the likely cause of this low incidence? We still don't know what's the exact reason of low incidence in children. This might be that there is in community there is mitigation measures being used. Children they are also wearing masks, and they are being trained to use hand sanitizer, and they are out of school. Schools are closed, but now from 15th September, partially colleges and schools they are open, but still all classes have not been allowed. In our Rawalpindi Medical University, we have called only third year and final year, and from first October we will call first year and second year, and then after 2 weeks we will call first second year class. So if the condition is permissible and there is no spread of COVID-19 in children, in students. Well, comparing trends in pediatric infections before and after return to in-person schools, that will basically tell us what's the exact incidence, why it's low incidence. And resuming other activities may provide additional understanding about transmission in the children. So because the disease is evolving, so we are not clear yet about the epidemiology also. Next, please. Well, globally, more than 30.8 million cases has been confirmed today of COVID-19, and there are more than 957,000 deaths till now. So it's a huge figure, and this data is changing day by day and hour by hour. And locally in Pakistan, till today, we are having 305,671 cases, and in Pakistan 6,416 deaths till today of COVID-19. Globally, fewer cases of COVID-19 reported in children from 0 to 17 compared with adults, and children are about 2% of all cases. In various studies, it's from 1% to 7%. More cases were reported from America and of children, but its average is about 2%. And 23% of the children who developed this COVID-19 had underlying other illnesses like congenital heart disease or acquired heart disease, or chronic kidney disease, chronic liver disease, or any lung pathology, bronchiectasis, or bronchial asthma. So any child who is having any other disease, then likely there is chance that a patient child will develop more severe disease and may need admission. There is not only low incidence, but also low death rate in children. Next. Well, why we don't know the true incidence in children? Probably, maybe it's lack of widespread testing, because we are prioritizing the testing for adults, and those who have severe disease are those who have symptomatic. Here, policy in our Rawalpindi Medical University was that no symptoms, no test, no investigation. So if any patients or any attendant or even doctors, they request for investigation, our policy was if patient is asymptomatic, so there is no need to go for test. If the test is also costly, so you have to prioritize. So that means if children, they are asymptomatic or having mild disease, we might be missing that those children. So true incidence might be higher than the reported incidence. Then hospitalization rate in children significantly lower than adults. That's again because in children they are having less severe disease. That might be the reason. Secondly, children have less severe illness from COVID-19 compared to the adults, as I already said. Next, please. Well, in China, nationwide study done in China till June 2020, children comprise of 2% of all cases, and the mean age was 7 years, range from 1 day to 18 years, and there is no significant sex differences. Both sexes were almost equally involved, and clinical manifestations less severe than those of adult patients, and young children, particularly infants, more vulnerable to infection, and 94% of the all pediatric cases either asymptomatic, mild, or moderate. Next, please. Regarding USA, children, 7.3% of the all cases in United States. This is CDC data as of August 3rd, and 45% of the pediatric infections were asymptomatic, and children with certain underlying medical condition, they were having severe illness. So if the child is having, say, underlying condition, as I already said, especially heart disease, congenital heart disease, or acquired heart disease, or chronic liver disease, kidney disease, or lung pathology, they were having severe illness. And infants less than 1 year of age increased risk of severe illness, and low rate of mechanical ventilation and death than in adults. 1 in 3 children hospitalized with COVID-19 required ICU care, which is same as in adults. Next, please. Well, regarding need for hospitalization, hospitalization rate in children range from 2.5 to 4.1%, and 33% required intensive care, 6% required invasive mechanical ventilation, underlying condition associated with higher rate of hospitalization, 15 to 22 versus 2 to 4%, and ICU admissions. And age less than 1 year, as I already said. Then cluster of children and adolescents requiring admission to ICU with multi-system inflammatory condition, Kawasaki-like disease, and toxic shock syndrome. Initially, this was reported from Europe, and then you see America also. And we have also seen a lot of cases of this multi-system inflammatory disease in children. Next. So epidemiology of COVID-19 in Pakistan, briefly I will touch this also. Next, please. This is basically data showing total cases and recovered cases and death that I have already mentioned. And most of the cases, a majority of the cases were from Sindh. Sindh reported maximum cases, followed by Punjab and then KPK. Next, please. Well, this is children with COVID-19. You see, in Pakistan, this is Pakistan data till of 31st August 2020. Total patients, children reported with COVID-19 were more than 12,562. These were the cases reported from all provinces in whole Pakistan, and majority were reported from Sindh. If you see the graph, the bars on right side, this blue bar is of Sindh. Sindh reported 5,005 cases, and Punjab reported 3,357 cases, and then KPK reported 1,572 cases. Then from Balochistan, 1,403 cases. This 1,572 cases were reported from Islamabad Capital Territory. KPK reported 961 cases. And then Gilgit-Baltistan and AJK reported similarly 130 and 134 cases. So majority of the children, they were reported from Sindh and then Punjab and then Islamabad Capital Territory. And male to female ratio is 58% male and 42% of the females were infected. Next, please. Well, our own data in Allied Hospital of Rawalpindi Medical University, we had total 48 cases of COVID-19, and 32 were basically confirmed through PCR, and other cases were confirmed through CT of the chest. So CT chest findings were also taken consistent with COVID-19, and these patients were also considered positive cases and treated accordingly. And 12 cases, there was death of 12 cases, and all 12 had, multi-organ inflammatory disease, and they have, 2 or 3 organs involvement. And 60% of the all diagnosed below 1 year of age, and 12 cases had comorbidities, and poor prognosis in children with comorbidity, especially congenital heart disease. Next, please. So thank you very much. If there is any question, I can ask.
Yes, sir, we do have a couple of questions. If it's okay with you, I'll start.
Ji, please.
So the first question is, what was the commonest presentation of COVID amongst COVID positive children?
Well, the calmest presentation was fever along with respiratory symptoms. So almost all patients, they were admitted with respiratory, symptoms. They were having cough or difficult breathing, or they were admitted or being treated somewhere else as pneumonia. And later on, this was cough and fever were present in almost all patients. And later on, these patients, they develop, involvement of the other organs, but majority presented with pneumonias. They were being treated for pneumonia in the GP clinic or some other hospitals, and they later on they were referred to our hospitals.
Sir, we can't hear you properly. Sorry to interrupt.
I said that majority of the patients had respiratory symptoms. They were admitted with. Can you hear me?
No, no, sir, we can't hear you very well. If you could bring it closer to you, maybe.
Okay. Now
It was better for a moment.
I said that majority of the patients they were admitted had respiratory symptoms, pneumonia and cough and fever. Can you hear me?
I can hear you, sir, but it's very low.
Okay, I changed my position. Can you hear now?
Yes, sir.
Okay. I said that majority of the patients they had respiratory symptoms, and they were having either cough or respiratory distress or fast breathing, and these patients were admitted. They were being treated as pneumonia, and later on shifted to our hospital.
All right, sir. So the most common symptom were respiratory symptoms in your opinion.
Yes.
All right. Sir, so the next question is, have any vaccination trials started in Pakistan?
Vaccination trials are being done in Pakistan. University of Health Sciences, UHS, they and there are other institutions. They are giving having trial of vaccines.
All right, sir. But they haven't given any conclusive results as yet, have they?
No, yet we don't have a vaccine available. These are either phase 1 or phase 2 trial, and they will go for phase 3 trials. Only then vaccine would be available. So basically, UHS started trial, and then our DRAP, which regulates these drugs and other vaccine, they initially stopped. Okay, why you have started this trial without our knowledge and permission? Then UHS has to got permission from DRAP, and then they restarted the trial.
And they were trying COVID vaccinations or
COVID vaccine. Yes, COVID
Thank you,
vaccine.
sir. Sir, as schools are opening, what advice would you give to the parents about preventing patients from catching and transmitting diseases, basically children from catching and transmitting diseases?
Well, firstly, if a child is having any symptom, any symptom, say a fever or runny nose, respiratory symptom, cough, our child is not well, that child must not go to the school. Firstly, secondly, all children must have face mask, and they must have their own hand sanitizer, a small bottle in their pocket, so that they can use sterilize hands. And then certainly government has made clear guidelines. Okay, they have to sit at 6 feet apart, And in the schools have not usually called all classes. And even if they have called the classes, they have made it into badges. So that there is some, you see, social or physical, you see, distance between children. So that's the only solution. A child must have mask. Secondly, hand washing, that may not be possible everywhere. So they must have hand sanitizer with. And thirdly, they should have, you see, social or physical distance. These are the three things. That's how children can be protected. And secondly, firstly, I said that if any child is having symptoms, that child must be, you see, must not be sent to school. And similarly, they are in schools, they are checking for temperature of each and every child at the entry. And if any child is having, you see, fever, that child is sent back to the home. And in, you see, our Rawalpindi Medical University, we have called third year and final year only, 2 classes. And we are not doing lectures, although we are having a very big class. Our class is 350 students. We have made smaller badges, and they are going to clinical classes. So in the badge contains just 18 to 20 students. They are having their rotations in clinical wards, but we are not having a big class as we were doing before this COVID-19.
All right, sir, thank you. Sir, the next question is it possible that the viral load in children is different, or the sensitivity of PCR is different amongst children, which is why the incidence is low?
Sorry, again, repeat question.
I'm sorry, sir. Can you hear me now?
Yes.
Sir, the question is it possible that the viral load of COVID in children is different, or the sensitivity of PCR is different in the pediatric population?
Still, we don't know definitely. In certain studies, as I already mentioned, that viral load in oropharynx is similar to adults, and in certain studies, it was rather higher. So viral load is similar. And secondly, regarding positivity of PCR, positivity of PCR again depends upon the procedure. If the child is not cooperative, because you have to go into nasopharynx, nasopharyngeal swab is recommended. And if the child is not cooperative and you have not entered into nasopharynx, if you are here, if you take the swab from anterior nases, then there is a chance that you may not get, you see, result. So the patient child might be COVID positive, but as the adequate sample from a proper site has not been taken, so this might be negative. So this is the reason. So it depends upon how carefully and you have taken the swab. That's very important, because you have to teach the person who is taking these nasopharyngeal swabs, even in adults. So if you pass, you see that probe into the nose, so certain sometimes patient is having sneezing, or reflexly he extends the neck. So swab may not go into the nasopharynx. So you have to take swab from nasopharynx. So that in children is sometimes not possible, because the children are not cooperative. Sometimes young children, they start crying. So if you approach a child and the child start crying, so in a crying child, again, it becomes very difficult to pass, you see, to take sample from nasopharynx. So that's the reason basically.
All right, sir. Sir, so the last question that we have is, do you believe that the opening of schools is going to lead to a second wave of COVID, because children are the most popular, modes of transmission, as they say these days?
If you remember, at the beginning of these series, Professor Umar presented one slide in which he showed that there were 2 peaks in Pakistan. Second peak was basically after you see Eid. So because before Eid, everything was open and there was a lot of transmission, and then we had second peak. So because now schools are being open, there is definitely risk patient we may have you see increased cases of COVID-19 in children or as well as in the Pakistan. For the last few days, yesterday from Pakistan reported 700 and something, more than 700 cases. Although it came down to 300, but yesterday there was 700 cases. So there is risk always. There is risk if there is patient we may have you see more cases. So the only thing is we should have we should educate our community and each and every people, students, and only then we can. Although this is a preventable disease, it's a preventable, as I already mentioned, that the doctors and paramedics and healthcare professionals who are working in COVID-19 ICU, which is having you see all serious cases, and you have to pass those patients who are on ventilators, you have to pass endotracheal tube, and passing endotracheal tube is great risk because you have to be closer to the patients, and there is risk you may get you see virus. So these all doctors and paramedics, they were safe. Why? Because they were observing SOPs. So it's a preventable disease, and if you do hand washing and you don't touch you see hand to the mouth, nose or face, and you are having face mask while you go outside, and if you teach and you see counsel the parents and children, I think we can safely we can save our children, and it's a preventable disease.
Thank you so much, sir. That concludes the question and answer session for us. Thank you.
Well, sorry, I want to. No one has asked this important question: why children are having less severe disease? Why the incidence is less, and why they are having less severe disease? So there are 5 reasons. Although at the start of the you see my presentation, I said although we know a lot of things regarding COVID-19, but yet we know very little. So, the explanation which was in you see in a recent article, it was that number one reason is that the receptors, angiotensin converting enzyme 2 receptor, where virus has to attach and respiratory tract, are less you see in number in children. This is the first reason, that the receptors in respiratory tract of children are less. This is one reason. Okay, why these patients are, why it's less common in children. Second reason is that children are having respiratory infections. Respiratory infections are common in children, and other coronaviruses, they also leads to common cold, runny nose in children. So these common cold, caused by other coronaviruses may protect children also, because they are having immunity against those coronavirus, and then they might be having cross immunity. Third reason is that there are T helper 2 immune response, which is more marked in children, and they say that T helper 2 immune response is also protective in children. And along with this, fourthly, eosinophilia is also present, and which is also you see protective along with T helper 2 cells. And then lastly, number 5 reason is why the disease is less severe in children is that children generally produce lower level of inflammatory cytokine. The cytokine storm, which is present in adults, is less severe because the cytokines, inflammatory cytokines, they are produced at a smaller rate, and they are less, you see, prone to develop this inflammatory response in children. So these are 5 major, you see, reasons why the children are less affected and they are having less severe disease.
Thank you, sir. That is very informative. I think that all of these reasons and speculations should be taken into consideration, especially when we're treating children. So thank you for sharing all of this valuable information with us, and thank you for giving us your valuable time, sir.
You're welcome. Thank you very much for giving me the opportunity to interact. Thank you very much. God bless you.
Thank you, sir. This concludes our session. Marvish, I'm going to hand over the mic to you to introduce our third speaker. Thank you.
Thank you so much. I'm honored to announce our third speaker for the night, Professor Major General Salman Ali Hilal Imtiaz. Major General Salman Ali is a professor of pediatrics and principal of Fazaya Medical College affiliated with the Air University. He hails from Hunza Valley, Gilgit-Baltistan, and belongs to the royal family of Hunza. He received his early education from Hunza and then from Gilgit. He then went on to Edwards College in Peshawar for FSc. Brigadier Salman Ali did his graduation from the King Edward Medical College, Lahore in 1980. After doing his internship in Mayo Hospital, Lahore in internal medicine, surgery, and ophthalmology during 1980 and 1981, he joined the Army Medical Corps. He passed his FCPS in 1987. He did his post-fellowship on job training in pediatrics and neonatal from the UK in 1988 to 89. Major General, he has supervised most of the postgraduate trainees in pediatrics from the armed forces, as well as a number of PGs from the civilian institutions at MH Rawalpindi. He established neonatal intensive care facilities at MHCMH Rawalpindi and introduction of training in neonatal pediatrics for second FCPS at Military Hospital. Professor Major General Salman Ali has been ensuring the provision of all specialized services in his department, including pediatric intensive care, and a pioneer in starting both upper and lower gastrointestinal pediatric endoscopy, as well as fiber-optic bronchoscopy services in military hospital. He has presented research papers in national, international pediatric conferences and has a number of publications to his credit. He has served as a member of the Faculty of Pediatrics of the CPSP and continues to be a senior examiner for MCPSP, FCPS Pediatrics, and FCPS Neonatal Pediatrics for the last many years. Please allow me to welcome Major General Salman Ali for his presentation. Assalamu alaikum, sir.
Assalamu alaikum. Thank you very much, Dr. Marvish, for the nice introduction. I'm really flattered and humbled. I hope I am audible.
Sir, if you could move slightly closer, it's a little lower.
Yes, I am audible now.
Yes, sir, it's better.
Clear now, audible?
Yes, sir.
Okay, thank you very much. I would first like to thank you for inviting me, and I would particularly thank Professor Samia Naimullah for organizing this webinar and giving me an opportunity to come here. And I would also thank my teacher, General Mahmood Akhtar, who is the patron of these webinars, and all of you who are there arranging these webinars. Really, you are doing a great educational service for the pediatric community as well as our general medical practitioners and our health workers who are looking after children, particularly in this COVID era. I think my job has been made easier by the earlier two speakers. Particularly Professor Rai has presented most of the statistics from Pakistan, and Dr. Rathore has discussed the inflammatory syndrome which occurs in children post-COVID. So I would confine myself to the management of neonates in COVID-positive mothers, which we have encountered in our practice of neonatology, both in Pakistan, and we have definitely, from the world over experience, we have learned about the neonates and the mothers who have been COVID positive, and we have been involved in arranging their care in our wards. And initially, in fact, we were very much scared as how to really look after the mothers, where to arrange the newborn care, where to arrange the resuscitation for the deliveries. and many times the health workers, because this COVID-19 was certainly a novel virus, the health workers were really scared of going and attending the mothers and deliveries, you know. So initially, in fact, from the peripheral BHUs, you also heard the news that whenever the BHU staff heard that a COVID positive patient is coming or a suspected patient is coming, so many times it was found that the patient has reached there and the staff has disappeared. So these stories we initially had in the country, but now I think the condition has stabilized, and as we know about the management of the disease, as we know about the behavior of the virus, we are now more confident in managing the problems of the mothers and the newborns. May I have my first slide? Can you project the first slide, please?
Yes, of course, sir. Sir, I'm sorry. Could you maybe use a headphone or move in closer? Your volume is still slightly low.
Okay, I'll move closer because I'll speak a little louder because I am on the iPad and I'm not having a headphone actually. No, I'm not on the desktop actually. I'm on the iPad.
Okay, sir.
So I'll speak a little louder.
Thank you so much, sir.
So, so this is about the outcome of neonates born to COVID positive mothers, and we have to discuss the problems which we face and which any health worker is going to face. How we really move about to manage the mother and the newborn, particularly. Can I have the next slide, please? Next slide, please. Okay. Now, what are the implications of COVID-19 for pregnant mothers and their perinatal management? Now, the number of studies which have been done on pregnant females world over, as well as within Pakistan. Now, the main gist of those studies is that COVID-19 in pregnant females is no different from the general population. That means it may be as severe as it is in the general population, it may be as mild as it is in the general population. The feto-maternal outcome is generally good. And the good thing so far is there is still no definite evidence of a vertical transmission in any newborn. So whatever reports are there from newborns, most of the reports are of horizontal transmission. That means it's a postnatal transmission in the newborn. So we have to save the newborns postnatally. But overall, as far as the maternal vertical transmission is concerned, which was initially suspected and initially thought of, so now it is, so far, we have not found any evidence that this is transmitted vertically or it is transmitted through the breast milk. Rather, it has been rather postulated or that the neonate might in fact be protected by antibodies which the mother produces and that get transferred in the breast milk, and also through the transplacental transmission of the antibodies. In fact, those might prove to be protective for the neonates, and whatever problems occur in the neonates, the transmission so far has been postnatal rather than vertical. Next slide, please. So the outcome of COVID-19 is generally good in infants, and even not only neonates but in infants and young children, as you saw in the earlier presentation. There have been few case reports of COVID in neonates and infants, but with good outcome. In fact, the youngest neonate who has been reported with COVID-19 has been a 26-weeker preterm neonate in the US. And this 26-weeker has so far done well, and both the mother and the neonate have been discharged from the hospital. And as far as Pakistan is concerned, we had one report from the military hospital Rawalpindi, a 26-day-old neonate presented with features of COVID-19, but finally with a good outcome. Of course, there was respiratory distress and she needed oxygen, but the case has been reported in the Pakistan Armed Forces Medical Journal. So that has been the report from Pakistan, and there have been reports from Italy, and there have been reports from Wuhan, China. And there also the neonates have had mild illness, and they haven't gone on to need really ventilation, but most of them have recovered with oxygen and CPAP. So the outcome universally in neonates who have had COVID-19 has generally been good. And the incidence, there has been no incidence or evidence of vertical transmission in all these case reports. But rather, there have been 5 infants reported from Paris, France, where in addition to the respiratory symptoms, these 5 infants had neurological symptoms also. But again, they had mild disease, and all 5 of these infants, they recovered. So you see, there have been isolated case reports in neonates from the world over, from China, from Italy, from Paris, from USA, and also from Pakistan, with good outcome. And I think most of these cases have been most likely due to the horizontal transmission rather than the vertical transmission. So the emphasis should be considering the outcome of these neonates and the pattern of the viral infection in these neonates. The emphasis should be on postnatal prevention of the COVID-19 infection. And the guidelines which have been now devised both by the Ministry of Health here in Pakistan, and also the guidelines by the CDC and also by the Canadian Pediatric Association. So most of these guidelines now are based upon the presumption that there is virtually so far no evidence of vertical transmission, but we have to prevent the horizontal transmission, and the health workers have to protect themselves in managing the COVID positive mothers as well as the neonates. So the guidelines are based upon so far upon the results of these neonates who have been encountered in this whole COVID epidemic. Okay, next slide, please. Now, the worldwide, as I said, the case reports both from Pakistan and coupled with our own experience at our own health facilities are indicative of the same thing, that neonates have infection through horizontal transmission rather than vertical. And the one important problem which the health workers who are managing neonates should remember is that neonates are more likely to suffer from the common perinatal problems even during the COVID era. So even during the COVID era, we should not really suspect all of them about that they are having COVID. Rather, we should be managing the routine perinatal problems like the respiratory distress syndrome or meconium aspiration syndrome and birth asphyxia, our preterm and low birth weight babies, and neonatal sepsis. These are the common neonatal problems, and they are still there despite the COVID around. They are still there. So the neonates should not suffer, their management should not suffer because of the COVID. This is a very, very important arena which we should emphasize upon our health workers. Next slide, please. Yes, next slide. Yes. So the neonatal health workers, we should be geared for management of the common causes of neonatal respiratory distress and neonatal sepsis, and what we call the para-COVID effects. We need to address those. The para-COVID, because of the fear of the COVID, most of the neonates, they suffer. For example, many of our neonates, they did not have their primary vaccination, their BCG vaccination, and many of the infants, they missed their later vaccinations, and even the routine sort of respiratory problems like surfactant deficiency or meconium aspiration syndrome. So many of the units, they started doing the COVID tests for them. So, and they turned out to be negative. So these are the para-COVID effects which need to be addressed, and that means we should remove the excessive fear of COVID from our health workers, and we should emphasize upon them that if they follow the due precautions and have their protective equipment, the PPEs, they need to ensure all these in all COVID and suspected COVID when they attend mothers, when they attend deliveries, and they should follow the SOPs. And I think we have made the SOPs in all our hospitals, and even the Ministry of Health has issued, the Pakistan Pediatric Association has issued all these guidelines, and these are available for our health workers. And if they follow them, I don't think they will be at risk. And so far, it has been found that our neonatal postgraduates or our neonatal medical officers who attend the COVID positive mothers and attend the deliveries, fortunately, none of them have so far had any COVID infection because they followed the proper SOPs. So therefore, that fear should not be there. Okay, next slide, please. Now, the first problem which comes when you manage a COVID positive mother and when you manage delivery in the labor room of a COVID positive mother is how to resuscitate the neonate. So neonatal resuscitation protocol, it has to go according to the NRP guidelines, and there are guidelines for neonatal resuscitation, and all of us, we follow those. But you have to follow the proper protocol, and personal protective equipment has to be ensured for all health workers. So we recommend that since neonatal resuscitation involves, it may involve endotracheal intubation, it may involve suctioning, and it may involve administering oxygen and bagging in the delivery room. So therefore, all our health workers who go to attend, both the nurse and the medical officer, and the pediatrician who go to resuscitate and receive the units in the neonatal in the labor room. And generally, we hospitals have separate labor rooms areas for COVID positive mothers. And similarly, the neonatal resuscitation area has to be totally separate for the neonate. And these workers, health workers, they have to put on not only their N95 masks and the proper gowning, and they have to put the protective face shields also, because they are likely to have potentially aerosol generating procedures like endotracheal intubation and suction. So that recommendation has to be added. And then after that, the neonate has to be transported to the neonatal unit. And generally, those who have got space, the COVID positive neonatal unit is generally separate from the other neonates. So an isolation unit is made for these neonates. And there are nurses there. And similarly, the COVID positive mothers, so they have got a separate isolation area in the labor ward. Next slide, please. So after the neonatal resuscitation comes the neonatal transport, and the neonatal transport, that has to be separate with all due precautions. If you have got an transport incubator, okay, that should be reserved only for these COVID positive mothers, neonates of COVID positive mothers. And similarly, the cot, that has to be in which they are transported, so that has to be separate. Or if the neonate is transported manually, so all the workers, the nurses who transport the neonate to the neonatal unit, they have to be properly gowned, and they have to have their N95 masks and face shields. So that's very, very important. Even if the neonate has to be nursed along with the mother, again, they have to have their PPEs, and the mother should also have the routine because when she's going to handle the neonate, so she has to wear a mask, and she has to have her hand sanitization, and the health workers have to maintain a social distance of at least 2 meters from the mother. Next slide, please. So the postnatal management of these babies with COVID-19 mothers, it involves their management in the NICU, and rooming in with the mothers, and then the lab tests, the PCR for COVID-19. So in the NICU, one should have a separate area for these babies who are born to COVID-19 mothers, and they should only be shifted to the NICU if they have got a problem, a respiratory problem, or they need oxygen. Generally, neonates who are born and they need oxygen, or they are in respiratory distress, and they are born to COVID-19 positive mothers, generally at birth, they would have the usual routine problems of either birth asphyxia or problems of respiratory distress due to prematurity or meconium aspiration syndrome. So they should be managed accordingly according to their merit, and they should not be considered as having a COVID-19 issue. Well, okay, they might be carrying the virus, but once they are wiped clean, and they should be managed according to the routine neonatal protocol of the unit, because COVID-19 infection, even if it occurs in these neonates, it is secondary to postnatal transmission rather than vertical transmission. So all problems which occur at birth are not due to COVID-19, they are the routine neonatal problems. So these neonates have to be nursed accordingly, and once they recover and when they are handed over to the family, the mother should follow the routine of proper masking and proper sanitization when handling the neonate, when breastfeeding the neonate, because she can transmit the virus postnatally. Now, the recommendation for rooming in mothers, they are definitely set recommendations, both in case the mother is COVID-19 positive or COVID-19 negative. So if the mother is COVID-19 positive, the recommendation all over is that she can breastfeed the neonate with all precautions. The only thing is she has to put on the mask properly. She has to sanitize her hands before she handles the neonate. And she has to clean her area of the mammary glands well before the newborn is put to the mother's mother for breastfeeding. So those routine precautions have to be followed, and there is no need that the neonate is separated from the mother. Although initially there was a recommendation that these babies should be nursed separately from the mother for 14 days till the mother's PCR is negative. But now this is no longer a recommendation. The recommendation is the mother should follow the routine protocol of putting a mask, sanitizing her hands, cleaning her area of the mammary glands well with the sanitizer, and then putting the baby to the breastfeed. And if they follow this routinely, strictly, religiously, there is no risk that the infant would be at risk of acquiring COVID-19 infection. So rooming in with mothers is again a recommendation which is almost universal by all the associations, including the Ministry of Health of Pakistan also. Now, the lab tests for PCR for COVID-19 are quite expensive. And initially, the Ministry of Health had recommended that the neonate should be tested after 2 days and then frequently tested till 2 tests are negative, and then you declare that this neonate is no longer carrying the virus or no longer infected. But I think if a neonate is born to a COVID positive 19 mother, then the best thing is, once you have followed the precautions and the breastfeeding, so postnatally, probably at day 14, if you do the PCR and the mother's PCR is negative and the baby's is negative, they are safe for postnatal management at home. And even mothers who are well and they have COVID-19 positive, they are well and they can be managed at home. So with all precautions and with due proper training and education and apprising the family of the implications, I think the same precautions can be carried out at home and they can be managed at home. Next slide, please. So the recommendation regarding breastfeeding, as I said, since breast milk transmission of the virus is very unlikely, there is no evidence, nobody has proved that this virus transmits through breast milk. Rather, it has been found that if the mother has got the antibodies against the coronavirus in the breast milk, this might be beneficial for the infant. And the other important thing is maternally transmitted antibodies from COVID-19 positive mothers. Again, they might be beneficial for the neonate and they might be protective for the neonate. So this might be one factor that why the disease is mild in the neonates and why they are less frequently infected. And even if infected, still they continue to have a milder presentation, and they are generally so far, despite the widespread epidemic, they are really safe from direct effects of the virus. And in fact, they are suffering more from the para-COVID effects, from the uh, neglect of the routine healthcare facilities provided to them because of the COVID pandemic. Next slide, please. Yes, so we can have safe conclusions as far as the newborns are concerned, that the outcome of neonates born to COVID positive mothers is generally good. So this is a consensus which has uh, developed after looking at the reports from all over the world, including particularly the hard affected countries, the hard hit countries of it started from China, and there are reports from Wuhan of the outcome of neonates of the babies in Wuhan, and it's very, very positive. Again, from US and from Italy and from all over the world, including Pakistan, the outcome has been generally good. And we have seen that wards were filled up during the peak of the epidemic, but it was not so as far as the neonates or the pediatrics was concerned. So the health workers, of course, they need to protect themselves during the various procedures following delivery, including neonatal resuscitation in the labor room and during management, particularly aerosol generating procedures like endotracheal intubation and airway suction, whether they do it in the labor room or whether they are carrying out these procedures in the neonatal unit on babies of COVID positive mothers. They have to protect themselves. So these are the important things which are of practical implications in terms of babies of COVID-19 mothers and the outcome of neonates. So I think we are safe to recommend breastfeeding with all precautions which the mother has to take. So the mother has to take the same precautions which the health workers are taking in preventing transmission of the virus, in protecting themselves from the virus. But here the mother has to protect her neonate from the transmission of the virus. So I think with these precautions, it's so far we have been able to really manage our neonatal units and our perinatal management of COVID positive mothers, and as well as the neonates has so far been has had a very good outcome, and we had following the international recommendations, we had no problems as far as the mothers and neonates were concerned. And I think the fear of the health workers has also been now duly addressed, because it has been now shown with full evidence that those health workers who follow the protocols, who follow the PPEs, and who really attend all these with properly equipped PPEs, face shields, there has been no incidence and no incidence of any infection in health workers. So therefore, I think the pandemic has come to a stage where we are now fairly clear about the management of the newborns, as well as the protection which is needed for the health workers. And of course, how to really address the concerns of the mothers about the breastfeeding of the neonates. I think with these important conclusions, we can safely come to the end of this lecture, and we can address any questions which anybody can raise. Thank you very much for your patient listening.
Thank you, sir. Thank you for this information. With your permission, yes, I would like to ask some questions from the participants. Our first question is, what are the SOPs for a premature baby born to COVID positive mother?
SOPs for
A premature baby who's born
for
to a
the
COVID
health workers,
positive
you mean?
mother.
Yes.
No, for the health
Yes.
workers and also,
Actually,
yes,
the
basically healthcare
preterm
workers.
babies, as I said, there has been only one report of this COVID positive neonate 26-weeker in the US. But the protocol is, when you have got a COVID positive mother, all the gynecologists, the obstetricians, all of them, they are having the full protective equipment, including gowns. The N95 mask is very important, and along with the face shields and head cover, and of course gloves. So they have to be fully protected. So when they deliver the baby, and there is, currently a trend for delayed cord clamping, which is beneficial for the baby. So it has been recommended that because of the COVID, fear of the COVID, you should not delay. You should not hasten the separation of the cord. The delayed cord clamping can be practiced safely. And once the baby has been separated from the mother, the baby would be handed over to the pediatric team. Now, the pediatric team, generally there are two protocols. One is, if your resuscitation area is inside the labor room, the pediatric team, they have to protect themselves, again with full PPE and face shields. But generally, the most of the hospitals have made the resuscitation area just outside the labor room, and the baby, once, is immediately quickly transported to that area just outside. And when the baby is resuscitated in that area, these health workers who are resuscitating the baby, they are relatively safe, but they have to have their full PPEs and face shields, because preterm neonates, generally they might have RDS, so they would need intubation. They might need surfactant administration right at birth. So these are potentially aerosol generating procedures. So therefore, these health workers have to be fully gowned, gloved, N95 masks, head covers, and face shields fully when they resuscitate the preterm neonate. And if the neonate has got any problems, and definitely this neonate needs to be transported to the NICU. So this neonate has to be transported in a separate transport incubator if the NICU is at a distance. And if it is close by, so they can quickly wrap the baby in warm wrappings and quickly transport it to the neonatal unit, depending upon what is the state of the baby. Is the baby on ventilation, on ambuvec, on oxygen, or the baby is safe and pink in air? So the transport can be managed accordingly. And in the neonatal unit, again, there has to be a separate area where these babies have to be managed with full protective equipment by the health workers who are managing. So this is how this thing, and in most of the neonatal areas, we have separate areas for these COVID-19 positive mothers' babies. And fortunately, even they are born to COVID-19 positive mothers. So far, we haven't had any illness in these babies, and they have had their, as I said, the usual routine neonatal problems. Because all these neonates who are having problems right at birth, they are having their perinatal problems. They have nothing to do with COVID-19. The only thing is you have to protect yourself as well as the neonate from COVID-19, because the risk is the postnatal transmission. The postnatal horizontal transmission is the risk in the neonate. Vertical transmission is not a problem, or breast milk transmission is not a problem. So I think, have I
Okay, sir.
answered clear, or do you want any more
Yes, sir.
elaboration?
Yes, sir. That would... Sir, maybe elaborate a little bit more on the management of the preterm baby who was born to a COVID
Yes, the
positive
COVID,
mother.
as I said, the COVID positive mother, where a preterm baby is born, the prematurity is not because of COVID positivity of the mother. Prematurity has got its own causes, and these premature neonates would have otherwise born even if the mother had not had COVID positive. So that COVID positivity in the mother does not affect the management of the neonate on its own merits, because this neonate can have, say, RDS usually, and they need surfactant administration, and they need ventilation. They might need CPAP and oxygenation. So during this period, they have to be managed properly in the neonatal unit. And once they are fit to be discharged from the neonatal unit, and I think then when they're ready to go home, then of course you have to instruct the family how to protect the neonate. The mother has to be isolated. The mother has to have the proper N95 mask, and the mother should also have her sanitization, cleaning of the hands, washing of the hands, and her mammary gland area should be cleaned before these babies are put to the breast. And the one thing we do, we continue to get expressed breast milk from the mother during the separation. When the baby is in the neonatal unit, you can obtain, with all precautions followed, expressed breast milk from the mother and feed it to the neonate. And now that is safe for the neonate, so that improves the neonatal outcome. So I think as far as the COVID-19 positivity in the mother is concerned, immediate neonatal period, the preterm is going to have through the same protocol where the other preterms are going. The only thing is this neonate is going to be nursed in a separate area. Although if you clean the neonate clearly, right from the labor room, if you clean the neonate, there is no risk of viral transmission. So the neonate remains to the risk of horizontal transmission, of course, postnatally, and that has to be prevented. That is very important.
Thank you so much, sir. Sir, has the criteria for neonatal resuscitation changed? For example, the number of minutes for CPR, for example, or anything else?
Actually, the neonatal resuscitation protocol remains the same in principle, but only there are areas in which the recommendations change. This neonatal resuscitation, generally we follow the NRP, which is the national recommendation by the American Pediatric Association and by the American Heart Association. So this is generally the recommended neonatal resuscitation, and there is a whole textbook of neonatal resuscitation where you follow the protocols. And the protocols is that previously people used to do the EPGAR scoring for neonatal resuscitation. But EPGAR scoring is done at 1 minute, where you see the activity, the pulse, the respiration, the grimace, and their muscle tone, and the color of the baby. So you don't wait for 1 minute. the decision for resuscitation has to be taken within the first 20 seconds. So the first 20 seconds are taken for drying the baby, cleaning the baby, and positioning the baby on the resuscitation table, And then you decide on the basis of the heart rate, the color of the baby, and the respiratory activity. Basically, these three things you have to restore. And currently, the American Heart Association has added oxygen saturation, monitoring of oxygen saturation has been added as one of the additional parameters where you have to see that the oxygen saturation is more than 90%. So that really tells you that the resuscitation is going good. And the other important problem is the recommendation for meconium stained babies has changed. Previously, what we used to do is that if the baby is meconium stained and you find meconium in the visible meconium in the mouth, so we used to, after suctioning the meconium, we used to do the endotracheal intubation and quickly suck out the trachea directly before we resuscitate. But currently, for thin meconium stained babies, this is no longer recommended. So currently the recommendation is you can suck out the pharynx and start the resuscitation straight away so that you don't delay the resuscitation. So this heart rate and color and respiration, this cycle is the action decision cycle. That if the baby is breathing spontaneously and the heart rate is above 100, this baby is going to do well and its color will be okay and you can administer little oxygen. So most of the 90% of the babies would be resuscitated simply with stimulation and just managing the respiration. Only around 1% of the babies would require endotracheal intubation or cardiac compressions for resuscitation or drugs like adrenaline and sorabica for resuscitation. So the recommendations for neonatal resuscitation are fairly clear, and currently our neonatal association, the Neonatal Group of Pakistan Pediatric Association, we frequently run neonatal resuscitation programs for all pediatricians and obstetricians who are involved in the delivery of these neonates. And I think if these recommendations are followed, most of our neonates, we will prevent the postnatal damage to the neonates as a result of delayed resuscitation or asphyxia.
Thank you so much, sir. That was a very informative answer. Sir, we have another question. What is the site to swab a kid? And are we doing rectal swabs here in Pakistan?
Actually, in the neonates, you can have nasal swabs and throat swabs, but I think you are talking of swabs, rectal swabs.
Yes, sir.
Yes, actually, rectal swabs are not frequently taken. The reason is because the virus, it will take time to really get the excretion. So if you want to get the actual virus, so it has to be from the throat and from the nasal swab. So if you get a good specimen from there, that is the recommended. But in stools, excretion has been demonstrated, and people have isolated the virus from the stools, but it's not recommended as a routine rather.
Okay, sir. Thank you so much. Sir, we have another question. Is there any higher percentage of asymptomatic COVID carriers among children who can transmit the condition compared with other age groups? If yes, is there any specific reason for that?
Actually, children can transmit, but although a study has been done, it has been found that generally, children can be asymptomatic carriers, and generally, they have got milder illness, if at all, and they really tolerate the virus better. but I think they are not transmitters in the sense as adults are, because adults cough very hard, adults uh, talk very much, so during talking and during coughing they transmit. But children, yes, when young children are asymptomatic and they carry the virus into their homes, and they have got close contact with the elderly at home, those who are at risk, somebody is having diabetes, somebody is having hypertension, ischemic heart disease, or an elderly, they are old age people. So for them, these children can be a threat and they can transmit the virus because this is a close contact. So we should be really vigilant about that. And currently, in some of the schools, I think after the opening of the schools, there has been some incidences of increase in the incidence of, the corona cases have increased in areas, and some of the schools and colleges have also been temporarily shut after opening. So that fear is there, and children generally are, a threat to the elderly at home. Basically, that is the thing. Otherwise, in the general community, I think in the community mostly, since adults are moving around, it's mainly the adults who are really spreading the virus. But children have got the capacity to spread the virus within their close circles, within their close family circles. So they can be asymptomatic carriers and transmitters. But I think that needs to be watched out. And I think there are still studies going on that. And there have been question marks whether it is a major role. Has it really got a major role in transmission? It's still a question mark in journals. It's still, this question is being asked. So I think as the pandemic goes on, we'll be more clear about the answers in the future as more studies come up on this.
Thank you so much, sir. We have our last question. You said breast milk is protective as it has antibodies, but isn't direct contact during breastfeeding making the neonate even more vulnerable to catch the virus, especially if the mother is COVID positive?
Yes, I mean this fear has been there, and the mother can transmit the virus to the neonate. That is why when this pandemic started, the initial recommendation was isolation of the neonate from the mother for 2 weeks and giving expressed breast milk to the neonate for 2 weeks till the mother is COVID negative. But now it has been found, and I think most of the pediatric associations have recommended that despite the mother being COVID positive, if the mother wears a mask, if the mother sanitizes her hands well, if the mother wears a protective gown, and if her area around the mammary gland where the baby is going to be put, that is clearly washed and cleaned, and then the baby is put to the breast, it is safe. So I think it is quite a laborious task which has to be carried out, and these are the current recommendations. However, as I said initially, because of the fear, we had the recommendation that you separate the baby from the mother because there is a risk of transmission. And even the expressed breast milk was initially not given, but now when it's clear that's not transmitted through the breast milk doesn't contain the virus, expressed breast milk was given. But then when it was clear that if the mother follows the SOPs and the proper precautions, as I said, enumerated, she can safely breastfeed.
Yes, sir. Thank you so much. Professor Rai Asgar actually wants to come online and he wanted to comment on the neonatal outcome as well. So if you could have him.
Thank you very much. I want to share, you see, data from Benazir Bhutto Hospital. We had 17 COVID positive pregnant mothers. And this paper has been recently published in a special edition of Journal of COVID-19 positive, you see, special edition of Journal of Rawalpindi Medical College. We had 17, you see, COVID positive pregnant mothers, and there were 13 live births, and 4 were, you see, intrauterine death. So from 13 babies, live babies, COVID-19 nasopharyngeal swab was taken from 10. 3 were they took the baby home, and they refused for giving, you see, sample. So out of, you see, 10 tests which were done, all were negative. And test was also repeated 24 at 48 hours also, that was negative. And babies were followed up for 14 days, they were asymptomatic. So this is data from our hospital, and I agree with General Salman Ali that outcome of neonate is generally good. But well, in our babies, we continued breastfeeding, and we asked the mother for face mask and good, you see, hand hygiene and breast hygiene, as General Salman Ali was mentioning. Breastfeeding was continued, but COVID-19 test at 24 hours and 48 hours was negative, and at 14 days, all babies were doing well. Thank you very much.
Thank you so much,
Thank
sir.
you.
We have.
Really
Thank you so much for General.
experience.
Thank you so
For
much,
your
General Professor
communication,
Salman Ali.
critical experience. Thank you very much.
Well, thank you, sir. Thank you for such an informative session. We actually have Professor Mubin online as well. We would also like to comment on some additional things.
Hope you can you hear me now? Can you hear me?
Yes, we can.
Sir.
Okay, all right. I'm also going to try to share my screen with you to show you so these are the studies. There are several studies you can see on this. The latest one was in Lancet. This has to do with perinatal transmission of coronavirus. And as you can see, there's no evidence of perinatal transmission, which is really talking about transmission through the birth canal. There was one study from China that suggested that, but that study was poorly designed. And so and it was never believed that could happen. And so vis-a-vis separation, so when the initial recommendation came from the Academy of American Academy of Pediatrics, they recommended that the preference was to separate the baby from the mother, because we did not know much about it at that time. The current recommendation still says that that is really the preference, but they can, though, if the mother wears the appropriate PPE, the baby and the mother can be put together, and that for breastfeeding and such. But again, the baby should be kept in isolate and kept most of the time away from the mother, at least 3 to 6 feet in the hospital. So I think that's something that we need to be aware of. And there's still information that's coming out. There's no evidence that the virus is transmitted through the breast milk. This has been studied several times now. A question was asked by somebody in terms of transmission. There's a study from South Korea that shows that children 9 years of age or older are as likely to transmit the infection as adults are. And there's a subsequent study from Chicago now, which has shown that even the younger children can transmit the infection quite effectively. And so that idea, I think there's a misconception. There are two misconceptions. One, that children cannot get the infection. Yes, children can get the infection. This is an equal opportunity virus. It'll infect anybody. Children can get the infection as easily as adults do. It is that they are not that sick. The other misconception is that children cannot spread the infection, which is also incorrect. We know, practicing infectious disease for years, that and there's data for many other viral infections, that children, in fact, have a much high viral load in the respiratory secretions. And the study from published in JAMA Pediatrics confirmed that, and there's a subsequent study that has now confirmed that children are as likely, if not more, to spread the infection, because the JAMA Pediatric study suggests clearly showed that the viral load in the respiratory secretion of children was much higher. The 5 reasons, the speculations that Dr. Rai had mentioned, that the reason why children may not get a severe infection, I think that's an area of robust interest and research right now. Unfortunately, we do not have a proof that any of those are the real causes why children don't. They are speculations, and we hope, I mean, they are reasonable and sound speculations, make sense, make logical and biologically plausible sense, but this time will tell if they are truly the reasons why children do not get the infection as severe as adults do. In the meantime, we can be thankful that they don't. Thank you for giving me the opportunity.
Thank you so much, sir. That was really, really wonderful. And I'm pretty sure our participants enjoyed a lot.
Thank you, Professor Rathore, for your really elaboration. I think one thing still needs to be explained. As far as children, you have very clearly explained. But the other thing is, one thing needs to be explained, that why Pakistan is not really getting the coronavirus, not hard hit by the coronavirus as it was predicted by the Oxford studies. So far, still we are perplexed, and I think nobody has had any explanation so far that despite our shortcomings, why we are so far spared of the devastation of the virus so far in the pandemic. I don't know what happens in the future.
Thank you, sir. We are actually not spared. Sir, would you like to comment on anything else?
Maurice, you're asking me or somebody else?
I think it
yes,
has been
anyway.
quite comprehensive, and we have learned a lot. The other question which I want to ask Dr. Rathore is regarding this multi-system inflammatory involvement in children, because we see Kawasaki disease and other multi-system inflammatory syndromes, but having having its relation with the coronavirus, are we really sure that this coronavirus positivity is coincidental? That the child actually came with Kawasaki's and coincidentally is just having the coronavirus positive test? But is it really responsible for the multi-system inflammatory syndrome? And that is the question.
Yeah.
How we relate it to really its presentation? Although I think people have evidence that maybe weeks after the COVID-19, they present with, of course, with a cluster of these multi-system inflammatory syndromes, as we have seen in Pakistan also. But we can we really conclusively relate it in terms of the Cox postulates or so far?
Well, there's nothing conclusive about anything on coronavirus, COVID-19 right now. But there's something called the Hall's phenomenon, Hall's this postulate, which is epidemiological postulate. If things are epidemiologically related and they can be repeated and repeatedly proven, that's probably correct. So what we saw here is that these kids, at least in the United States, there was when we had the uptake, a higher number of cases in March, April, then we saw cases of MISC in May, June. We saw a lot of them, and then when there was a second uptake, and then after that, MISC basically vanished. nobody was seeing MIS-C. And then when there was a second wave of that, then 4 weeks or 6 weeks after that, we will start seeing a second wave of MIS-C. So I mean that is quite convincing that there may be some relationship. Is there a direct relationship that still needs to be proven? Important thing is that many of these kids who have MIS-C, I don't know if you were present when I talked about that. Let me see if I can find that slide. I will show you, because many of these patients do not fulfill the criteria for Kawasaki disease. And as you know, Kawasaki disease, there's also no diagnostic test for that either. So if you look at the, that presence of atypical complete Kawasaki was in very few cases. Less than the highest was on the class 3, which is 6.6%, and there was, that was thought to be Kawasaki-like disease. So if you take all of these cases together, it's 5% or less is the cases who fulfill complete Kawasaki. So one could argue, then what about incomplete Kawasaki? Well, incomplete Kawasaki is again. It does not make it Kawasaki, just more likely to be Kawasaki. So I think that evidence, there's not a. It's going to take some time to really, if coronavirus goes away and in the next year there's another wave of coronavirus and then we see more MIS-C, I think then that will be convincing that the two are related. But we don't even know what causes Kawasaki disease. It's quite possible that Kawasaki disease is caused by one of the coronaviruses that we have not identified yet. I don't know. Nobody knows that. But the epidemiological relationship so far is quite convincing so far that it is related to that. Since we don't have a test to confirm one way or the other, it's going to be hard.
Okay, thank you, Dr. Rathore, for the nice explanation. Thank you.
Thank you so much, Professor Rathore. Thank you so much, Professor Dr. Raya Asgar. Thank you so much, General Professor Salman Ali. If there are any other comments, I personally was really enjoying the discussion. I'm pretty sure our participants were as well. So if you would like to share something else, otherwise we'll move on. Okay, thank you so much, professors. We would like to still have you here for the closing ceremony. I would like to hand this over to Dr. Maham.
Thank you, Dr. Mavish, and thank you to all the professors for joining us and sharing such invaluable experiences from their own daily lives. So this concludes our question and answer session, and it also concludes the pediatric session tonight. I would like to thank all the professors for their time and the valuable information, and also for the participants for joining us. Please do not forget to fill the feedback forms, as certificates will be distributed based on that. I'm proud to say that this concludes the COVEB series, and it has been a very enriching experience for us, and we hope that you feel the same way. As we have mentioned time and again, this project was made possible by the efforts of numerous people in BFP. And on the forefront were our founders, Dr. Sabah Akhtar and Dr. Rabiel Tariq, who have some important messages for you. So I'll hand the mic over to Mavish again so that she can read the one by Dr. Sabah.
Thank you so much, Dr. Maham. Unfortunately, Dr. Sabah could not be here because of some personal reasons. She, however, did wish to. I will be reading her message. Ventilators for Pakistan was formed as a result of compassion and love, which was inculcated in me by my parents, Professor Dr. Khalda A.K. Akhtar and Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar at a very young age. My mother, a renowned gynecologist and academician who she followed in my grandfather, Colonel Ziaullah's footsteps by holding free clinics twice a week, along with helping anyone in need, especially by extending help to families to help educate their children. My father has the same mindset and treats all of his deserving patients free of charge, which also includes free medicines monetary help, food, and ration. His compassion to help those in need set the tone of putting the needs of others before our own, and I try to extend the same in my capacity. It is very important for me to help in whichever capacity I can to improve the healthcare system in Pakistan, and arranging these series of webinars is part of my dream. Reach high, for stars lie hidden in your soul. Dream deep, for every dream precedes the goal. Famously said by Mother Teresa. I want to thank the honorable speakers without whom we wouldn't have been able to enlighten the young doctors and other healthcare workers about the latest advances in COVID during this time of crisis being faced by the world in the form of this pandemic. Each speaker, who was an expert in their field and highlighted all the difficulties being faced by the healthcare workers in treating this novel virus and provided solutions to tackle it. I want to thank our Patron-in-Chief, Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, Hilal-e-Imtiaz, for his patronage. His love for academics was a driving force behind these informative sessions. He is a teacher of teachers. More than half of the speakers were his students somewhere along their academic journey. I don't have enough words to thank Professor Samia Naimullah, our patron, for these webinar series and also for the academic advisor for VFP. She was up to wee hours of the morning to help us organize one of the longest webinar series extended over 2 months with both national as well as international experts in the field of health sciences. She suffered a major loss. Her husband, Dr. Naimullah, passed away 2 weeks ago. Although she is completely heartbroken, but her compassionate nature couldn't hold her back in supporting this honorable cause of spreading knowledge and helping VFP in helping Pakistan. I want to extend my gratitude to Team RMU, especially to the Vice Chancellor, Professor Dr. Omer, Hilal-e-Imtiaz, Director Education, Professor Rai Azkar, and Deputy Director, Dr. Shazia, for helping us by accrediting these webinar series. Professor Omer encouraged us at every step, and without his help, we wouldn't have been able to achieve this. Dr. Rabil Tariq, the co-founder of VFP, is a force to reckon with. She is a young doctor pursuing her fellowship in USA, but her passion to help others was one of the reasons VFP came into being. She is always there to help and goes out of her way to come up with ideas to help VFP in achieving the goals set by us. Last but not the least, appreciation must be extended to the academic team of VFP, especially to the directors, Dr. Mavish Erkin and Dr. Maham Khalid. In spite of their professional work and personal commitments, they work day and night to organize these webinar series. Both of them are brilliant young doctors full of compassion. It was an absolute pleasure to work with them. Dr. Zaid Hussain, Dr. Muhammad Ali Bhatt, Dr. Meher Zia, Dr. Ibrahim Majid, Dr. Tuba Saeed, Dr. Sohaib Ansar, Dr. Fahad Athar, Dr. Amna Pirzada, Dr. Qadir Zafar, Dr. Pinar Farooq, and Dr. Mehreen Khokar. These are the names who are working in front and behind the scenes to help us make these webinars successful. All our volunteers work passionately to help VFP help Pakistan. How can I complete this without thanking Mr. Iftikhar Yazdani, who has his own IT company and is a very busy person, but he took out the time to work with us voluntarily to turn this webinar into a reality. He is the man behind the curtain who made it technically possible to successfully air it live on Facebook and YouTube. At this point, I would like to narrate my favorite quote, which was said by Winston Churchill. We make a living by what we get, but we make a life by what we give. My dream is to see every Pakistani getting the best healthcare in their own homeland and at nominal charges, making it affordable for all. Ventilators for Pakistan is the first step towards making my dreams come true. This is where I found my passion as well as my purpose. I will end this by saying, make a habit of 2 things: to help or at least do no harm. Thank you so much, Dr. Sabah Akhtar. This was a wonderful message. I would now like to invite Dr. Rabil Tariq, our second co-founder, to speak a few words. Assalamu alaikum, Dr. Rabil.
Walaikum salam. How are you guys?
We're good. How are you?
We're good.
Good. Thank you so much for doing just such a wonderful job, both of you, and for making this webinar a reality.
Thank you so much for having us be a part of this.
No, it was my pleasure, and I hope people learned from it. I had just a few things to say towards the end. So I really like the 14th Dalai Lama, and he said, love and compassion are necessities, not luxuries. Without them, humanity cannot survive. Our prime purpose in life is to help others, and if you can't help them, at least don't hurt them. We've often find ourselves lost and confused, and I've always crawled back from this oblivion through love and compassion. While they're my biggest strengths, they're also my biggest weakness. And through VFP, I wanted to make sure that I make love and compassion my strength and do something meaningful that translates into helping the people of Pakistan. I would like to thank all our esteemed guests who honored VFP with their time and their wisdom. I would also I'd like to thank them for all their contributions to the field of medicine. We hope at VFP that our humble effort to impart knowledge through these webinars will help save lives. I pray that the world comes out of this pandemic stronger and more resilient than ever. Thank you, everyone, for joining us and making this a success.
Thank you, Dr. Sabah. I think that it has been our honor to be included in efforts that were done by VFP, and just the amount of knowledge that we have gained by hosting these sessions has been an honor for us too, and I'm sure that Margaret feels the same way about it. And I would just like to thank you for giving me the opportunity. Personally, it was a time when I wanted to do something for Pakistan, and VFP came at the best time. And I think that it has been an extremely enriching experience for me, and it has been a steep learning curve where we learned different sorts of things and met some of the brightest minds in Pakistan, living in Pakistan and abroad, who had their own wisdom to share with us. So overall, it has been an amazing and an honorable position to hold that we have held in VFP so far. Do you have
That's
any?
absolutely correct. And I couldn't agree more with you. I think VFP gave us all a chance to actually do something, give back to our community, and this wouldn't have been possible without both of our co-founders and their dreams. And they enabled our dreams to come true while they were at it as well. So we are all very, very grateful to that.
No, it was our pleasure. Thank you guys for being a part of us, and nothing is possible without you guys.
Thank you,
ma'am.
Thank you so much. If you would you like to talk about the EICUs that is the next and upcoming project by VFP?
Yes, so that is a project that Dr. Sabah and I are very, very excited about. So basically, EICUs will bridge the gap of, let's say, the medical expertise that we lack in our remote areas. And I really feel that in a world where AI and technology is taking over everywhere, it hasn't really been incorporated as much as it can be within the field of medicine. With this project, we will make sure that highly qualified intensivists can reach out to the remote areas of Pakistan, and we can provide critical care to our sickest of sick patients. So what we will be doing is that we will be starting off with Balochistan. Our plan is to start an EICU there with the help of our IT team. We'll be installing 360-degree cameras, EMR system, and we'll be helping through volunteer doctors who are based in Dubai and in the UK to kind of help guide and tailor treatment for our patients there. So Dr. Sabah and I are very excited about this project.
No, and I do believe that we actually are one of the pioneers of EICUs in Pakistan. So I think it's going to be an amazing thing and a big achievement on your part, especially for bringing it here and introducing it. And it's something that is needed in Pakistan very, very desperately, I believe.
Sorry, Maham, I couldn't hear you too well, but I think you were saying that's going to help bridge the gap and it's going to be a new and innovative thing. And yes, that is true. Actually, we introduced this idea to the Prime Minister as well, and it was very nicely received. Just again, as I said before, we lack the expertise in our remote areas, and I think we'll be able to bridge the gap with this project. And hopefully we'll not only do this in Balochistan, but spread throughout Pakistan.
Inshallah, absolutely. So now, thank you so much for joining us, Dr. Abed. Now I would like to, with great honor, I would like to welcome our patron, Dr. Samia Naimullah, to say a few words.
Bismillahirrahmanirrahim. Can you hear me?
Yes, ma'am. Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum, ma'am.
Thank you so much. In the name of Allah Almighty, the most magnificent, the most merciful, our worthy Vice Chancellor, Professor Dr. Muhammad Umar, my respected colleagues and speakers from abroad and from Pakistan, co-founders of Ventilators of Pakistan, Dr. Sabah and Dr. Rabel, co-founders of Yadim Foundation, my dear colleagues, my dear friends, students and participants, Assalamu alaikum. Firstly, our heartfelt gratitude from me and from my brother, Professor Dr. Tayyib, to all of you for the condolences and a lovely tribute for my husband. May his soul rest in peace, and may Allah Almighty shower the blessings on you and your families. It is my proud privilege to be here today to welcome you all on the closing event of 11 sessions, which have been successfully carried out by the dedicated and devoted team of VFP in collaboration with RMU. This was one of the academic activity as a pursuit of VFP. Our praises and encouragement to the untiring efforts without whom this up till task was not possible. जो यकीन की राह पर चल पड़े, जो यकीन की राह पर चल पड़े, उन्हें मंजिलों ने बना दी, उन्हें मंजिलों ने बना दी, जिन्हें वसवसों ने डरा दिया, जिन्हें वसवसों ने डरा दिया, वो कदम कदम पर बहक गए. There were 11 sessions, all sessions of 3 hours duration, each carrying 1 credit hour. There were 3 sessions on medicine, and the speakers were Dr. Mujib Alam, Dr. Mujib Khan, Professor Dr. Muhammad Umar, and Dr. Zile Humayun. On the next day, Professor Muhammad Kamran, Professor Muhammad Khurram, Dr. Samina Fazal from USA, and Dr. Umar Rahman from USA. Then the psychiatry was another 3-hour session. Brigadier Professor Maudat Rana, Professor Dr. Rizwan Taj, followed by public health, Dr. Faisal Khan from USA and Dr. Abdullah from Pakistan. Dental surgery, Dr. Samir Riaz, Dr. Abdul Samad from Saudi Arabia. Surgery, Professor Musaddiq Khan, Dr. Javed Raza from United Kingdom. OBGYN was done by Dr. Zwana Chaudhry and Dr. Shehnaz Nawaz. Ophthalmology by Dr. Taimur and Dr. Hina. Dermatology by Dr. Faisal. I would really like to talk about them, but because of shortage of time, I've taken their names. In pediatrics, Dr. Ijaz, Dr. Bishara, and Dr. Aisha Benaz yesterday, and today's speakers, you know, Dr. Mobeen Rathod from USA, Dr. Rai Muhammad Asghar, and Major General Salman Ali. We are highly grateful to all the worthy and esteemed speakers who have come here and from abroad. They are the cream of their profession. They are institutions in themselves. They appraised with the important aspects and the most up-to-date aspects of pandemic COVID-19 in each field and their specialty. There were 19 speakers in all. The sessions were very interesting. The sessions were interactive. They raised a lot of questions and answers, and the feedback was superb. My special thanks to our patron-in-chief, Lieutenant General Mahmood Akhtar, Hilal-e-Imtiaz Military, for his consistent guidance. He is an academician and a source of inspiration for all of us. His hobby is writing articles, and even today, he must be writing an article in his own room where he's locked up for the last 6 months. Day in and day out, he's reading, he's writing his books, and he has got many articles to his credit. He was Principal, Army Medical College, DG Medicine, Surgeon General, and he was the only one to be designated with the highest post of academic military. We are all indebted to the Vice Chancellor, Professor Dr. Muhammad Umar Sitara Imtiaz, recently bestowed with the Tamgha Imtiaz for his services for COVID-19 during the last 6 months. I recall Professor Umar as a young, energetic Registrar of Medical Unit 32 years back in Holy Family Hospital, and Professor Bushra, another hard-working girl. His charismatic personality, his vision, and his perseverance has converted RMC to RMU. Thank you for your kind collaboration, Professor Umar. The Medical Education Department, under the leadership of Professor Dr. Muhammad Asghar as Director of Medical Education, my excellent colleague and a very hardworking and a committed person. You've listened to him today. And Dr. Shazia, his Deputy Director, an enthusiastic lady, on the top of everything. They've been very helpful to us, providing us necessary assistance in providing credit hours from the university. Thanks a lot. The starting point of all achievements is desire. Dr. Sabadeep Khanum Akhtar from Pakistan, Dr. Rabel Tariq from US started their journey in March 2020 to help humanity, people in need. They started Ventilators of Pakistan, starting from donation of ventilators. They have donated 8 ventilators now and other are waiting. And this is another successful academic activity. Dr. Sabah is a diligent, committed, infatigable young doctor who worked day and night and had sleepless nights as well. We used to talk at 2 a.m., 3 a.m., 4 a.m. in the morning, and she was always awake. Dr. Rabel, being busy in pediatric intensive care in US, gave her full support. And I had to wait. Well, Rabel will be back now, really connecting the time. And then she would say, ma'am, I've just come. I've just entered my house. So this is how committed she was. My applause to them for their consistent, constant work before and after the session. Director Academics, Dr. Mavish Arkin and Maham Khalid, with Dr. Asma, who was my student, energetic, enthusiastic, were able to make their presentations and got the credit hours approved. Dr. Mavish Arkin, co-founder of Jardin, who is a graduate of Army Medical College in dentistry, doing a lot of community and hard work with Jardin Foundation as a young girl. A very present personality, and you've been seeing her today. You've been seeing her many days, and even today, she's in front of you. She's a moderator, a multitasker. In addition to doing all these activities in the hospital, she had been with us. Incredible, and shabash bacho. Mavish once, really, I think it was hard for her to bear with me on the first poster when Sabah and I had asked her to repeat it again and again because there were mistakes, and she almost cried. But I think she managed, and now she's on top of everything. Dr. Maham Khalid, graduate of Shifa Medical College in 2017, with a pleasant smile and a dimple on her face. She had an avid interest in community work and throughout took part in the social work in her college. She had been helpful in conducting medical camps during the pandemic and continued to be a volunteer in rural neuropsychiatric clinic. In addition to her other commitments, when she was completing the paperwork for going to UK, and she also had her du'a khair in these days. She was working day and night for this academic activity. Thank you. Good luck, Maham, for your future endeavors. There are other extremely important academic staff whom names have been taken by Dr. Sabah Akhtar, so I'm not going to repeat them. To mention Danish Habib and Maham Arkin has brought all these graphics with all the posters for us, and we've been changing them from time to time. Mr. Iftikhar Jasdani, IT, are competent and skilled in his work. How much pressure and tough tension you must have gone through in this work, but your work is laudable, admirable, well done. You were the first one to come and the last one to go. How about the participants, without whom nothing was possible? Thank you all. I hope you enjoyed the sessions. In addition to your knowledge by the eminent speakers all over the globe, you can now fight the pandemic. फजले खुदा का साया तुम पर रहे हमेशा, फजले खुदा का साया तुम पर रहे हमेशा, पुरदम है तू तो नहीं खतरा उफ्ताद, पुरदम है तू तो नहीं खतरा उफ्ताद. I would now request our worthy Vice Chancellor, Professor Dr. Muhammad Umar, for his pearls of wisdom. Professor Muhammad Umar.
I think Professor Umar is not available at the moment. As soon as he comes online, we will put him through. I just want to thank Professor Samia for her kind words. I think that it was because of their leadership that we were able to deliver as much as we did. So it is really owed to them. Anything that we did was because of them and their amazing leadership and direction.
Thank you so much, ma'am.
And now I would.
No, it's okay. I was just thank you so much, ma'am. Your words meant so much. We were just thinking of how to hug you virtually. Dr. Ma'am, please go.
All right, now moving on. We, over the past few weeks and today, we've highlighted the amazing work that was being done by my colleagues at VFP. I would now like to take a moment and appreciate our amazing community for their support. Pakistanis living in Pakistan and abroad have been the real reason that VFP has come this far and helped during the pandemic in all the various ways that it did. Pakistanis truly embody the spirit of brotherhood, and it can be felt whenever there is a crisis in our country. I would like to invite all those generous members of the public to support our efforts as we try to set up the first few EICUs across the country in an effort to combine the expertise of patriotic Pakistanis abroad who have agreed to work with various hospitals in remote areas of Pakistan in order to deliver world-class care to the patients here. We have also been working in various flood relief programs to help our people in both Sindh and Balochistan who have been affected by the catastrophic floods. Help us help them in their hour of need. The details of the bank account are going to be displayed on the screen. You can also visit our Facebook and Instagram pages for any queries and to follow our relief efforts. Thank you so much for all of your support. Thank you. Professor Umar is online with us, I believe. So if it's all right, he still has some technical difficulties and will be joining us in a bit. If that is all right, I would like to invite Dr. Samia again for her closing remarks.
Dr. Umar is waiting for us.
Mr. Irzani, I think he's in the waiting
Okay, he
room.
says you can't hear me, but he's waiting. You can, let's see if you can try him again. Otherwise, I'll
Yes,
continue.
ma'am.
All right, ma'am. Just give us a moment. We'll try again.
He's heard you, he's heard me.
In the meantime, I would just like to go over the account
Sir,
details.
आवाज नहीं आ रही, वो आपको बार-बार कर रहे हैं। क्या हो रहा है?
The account is being managed by Rahe Kamar, which is there are partners, technical partners, and you can send in as much as you want or as little as you want. We are a Zakat eligible foundation, and any amount of help that you can give is going to be amazing, and if that is going to help us better the critical care in Pakistan. Amongst other efforts, VFP, as mentioned before, has made an internship program which helped people learn the EMR, which is something which is used in Pakistan and abroad. We had these webinar series, and we also managed to donate 8 ventilators. And we have a plan of donating more as the donations come in. Mavish, would you like anything to add? Anything else?
Yes, Dr. Maham, just that no matter how much you send, even if it's ₹1, $1, €1, £1, it counts. And you have no idea how many lives you guys will be changing by donating, not just for the EICU, but also for the flood victims. It is quite sad what people in Karachi, our brothers and sisters, are going through, and we would just like to help them. So do support us in any way, as little amount as it can get. It really matters.
Thank you, Mavish. As we wait for Professor Umar to come online, I think that it would be great to reflect on the journey that we've had, not just in terms of this webinar series, but also with VFP. It started when the pandemic was at its peak in Pakistan, and it was a time when I remember most of the VFP members would be up till late at night because we would be getting messages on our various social media asking for help because the situation had gotten pretty bad in Pakistan. And at that time, VFP and a few other organizations were considered something more than normal or out of the ordinary, I believe, because people believe that we would somehow have the power to save their relatives or loved ones when everything else or everywhere else people had given up. This was also linked to the shortage of ventilators across Pakistan. I believe that I wouldn't want to quote a wrong number, but we all know that the ratio, not just in Pakistan, but in developed countries like the US and the UK, you do not have the correct ventilator to patient ratio. And in Pakistan, the deficit was probably worse than in most other countries. However, due to the grace of God, and I believe also due to some efforts by our medical system, we did not get the sheer amount of cases that were seen in the UK, in the US, and in India these days. So I think that VFP has also done its part, and we would like to continue doing that with your help. I believe that Dr. Umar is online, so we would like to add him.
Assalamu alaikum, sir.
Walaikum salam. Thank you very much. Finally, I made it.
Yes, sir.
Thank you. You can hear me? Can I speak?
Yes, sir.
Okay, so thank you very much for invitation, and let me congratulate the organizer, the young organizers, as rightly said by Professor Samia Naimullah, that this was a very well arranged lecture series because I have been involved since the beginning, and now in the closing ceremony, I really feel honored and humbled to be the part of this noble mission. I think the ventilator is doing the best job. This is way to save life, and what holy books say that if you save one life, you save the whole mankind. So my once again appreciation to the all the organizers, and particularly to Professor Samia Naimullah who involved me, and let me assure all the organizer and you as a young doctors that the Rawalpindi Medical University is always stand behind all these noble missions. And if you're doing any future endeavors, inshallah, that Rawalpindi Medical University will be there. And also thankful to Professor Rayasgar, who is the key to Rawalpindi Medical University, and he is also our focal person for all these activities. So once again, thank you everybody, and let's hope and pray that the whole world and Pakistan will come out of this pandemic. And my best wishes for your future. Thank you very much indeed.
Thank you, sir, for your support. Without you, I don't think that these series would have been accredited and we would have been able to reach the wide audience that we did. So thank you very much for your support.
Thank you.
I would now like to invite Dr. Samia back for some closing remarks. I believe that it's going to take us a minute to get Dr. Samia back. She's here.
Okay. I thought Professor Raiskar has talked about the school reopening, and I would just like to say a few words about it as well. Dilemma these days, school should reopen or not? Well, our education minister said that classes, universities, and the bigger classes should open on the 15th September, then 6th to 9th on the 30th September, and on the 23rd September in primary school on September 30. But all the SOPs has to be maintained. I have a chance to talk to a few teachers. What are the SOPs which are going to be maintained? The classes will be split into half. Where there are 40 candidates, there'll be 20. They'll go to school about twice or thrice a week. And then they will have hand washing every 10 minutes. Today, somebody came to me for taziyat and I asked her, तो उन्होंने कहा कि जी हम हर 10 मिनट के बाद बच्चों के हाथ साफ कराएंगे. मैंने कहा जी, is it possible? How would you do it? So the other things is that they'll all have masks. And they said the first day that kids came, they were so happy they hugged each other. And they were stopping them, but they wouldn't stop. We say that we've lost 6 months. But let me tell you, when I was counting, 3 months are always the summer vacation. So how much have we lost? 3 months. And the kids have been on online teaching, and but unfortunately, some of the parents got very tired. कि ये ऑनलाइन टीचिंग ने हमें बहुत परेशान किया है, हम घर में कुछ काम नहीं कर सकते. So there are different parents want different things. There are certain parents who are saying, बस बहुत हो गई, अब स्कूल जाएं. We know it's important for the child's mental health. It's important for child, but they cannot do all the activities. They cannot play there now. They cannot be in the playgrounds. They cannot have the morning meetings. They cannot have any other things going on. So they'll be confined to the classrooms. मुझे याद है, there was a patient who came to me and said कि जी मैं बच्चे को कल स्कूल भेज दूं. So I said, she's got 104 temperature. उसने कहा डॉक्टर साहब कोई बात नहीं, एक तो देखें उसका मेडल रह जाएगा, और दूसरा आपको पता है ना बच्चे घर में कितना तंग करते हैं. So the different parents have got different temperaments. I was just reading the Medscape on September 14 by the COVID Research Council. It was written for the waiver. the parents have to sign a waiver saying that if something happens to the child in the school, who is responsible? It is the child. The parents are responsible, not the school. So if the child is sick, not well, don't send to school. But how about the kids who are already infected there, who may be asymptomatic? How about the teachers? How about the other personnel? How about the buses, vehicles carrying the children along with them? So there are a lot of things which are still incomplete. How are we going to do it? In the last 48 hours, how many schools have been closed? At least, I think, 22 schools that have been closed. And the IBM from Karachi, from Gujranwala, from Hyderabad, and even in Islamabad, from Nankana, there have been cases which have been reported in children, in teachers. So the question is, what should really be done? Are we prepared for that? Are we prepared for all this? All the SOPs being carried out? All the classes being ventilated? All the classes being cleaned after every class which is finished? Yes or no? I have a feeling that it should be the parents' decision whether they want to send their children to school or not. And God forbid, if any case occurs, if anything happens, I think it's very important to stop that right away and to close. We know there is a college in Islamabad. The hostel has been closed because there were 16 cases in the fourth year students who were found to be COVID positive, and others were tested or not. How many kids are being tested? How many adults are being tested? Our testing is still very low. And that day we had about 730 cases. So what are we going to do? It should be the parents' decision. And the parents, if they want to send their children to school, they're only going for 3 days. So another 3 days, if a year is lost, what does it make in a lifetime of a child? But where all the SOPs, where all the precautions are being taken, we can say yes. But which are the places, which are the private schools, where they would be taken? And who will be guilty if something happens? When my child receives, God forbid, becomes COVID, who is responsible, a parent or a child? This is what I had to say about it. And finally, just ending, I would say the VFP, our ventilators of Pakistan, are growing very fast. A lot of people are entering, and a lot of people want to join this noble cause. First, they were working for humanity. They were working for academic work, but now they put all their efforts for Karachi and Balochistan effectives. And I think for these, they would really need the donations as well. मगर इनके साथ ही मुझे एक शेर याद आ गया, मंजिल से आगे बढ़कर मंजिल तलाश कर, मंजिल से आगे बढ़कर मंजिल तलाश कर, मिल जाए तुझको दरिया तो समंदर तलाश कर, मिल जाए तुझको दरिया तो समंदर तलाश कर. खुदा हाफिज.
Hafiz ma'am, thank you so much for these lovely words. It was an honor to have you with us and an honor to have you lead these series and for all the amazing advice that you would give us at all the odd hours that we would ask for it. As we say our goodbyes, I would like to say that it has been an honor to be a part of these amazing series. I would like to thank Lieutenant General Akhtar, Professor Samia for patronizing these series, Dr. Sabah and Dr. Rabe for leading from the front. Thank you to the many speakers for honoring us for their presence and experiences. Thank you to the amazing team who supported us throughout, Mr. Izdani, Zaid, Ibrahim, Dr. Muhammad Alibad, Dr. Pinar, Dr. Amna, Qadar, and many others who helped us make this a reality. And a special thanks to my host, Mavish, for being the best director and for being the best co-host. Thank you so much. This would not have been possible without you.
Thank you so much, Dr. Maham. Very honestly, the pleasure has truly been mine. Without such a strong team and support system that stood by us through every step, we could not have achieved what we have so far. VFP was initiated with the vision to help Pakistan, and it is such an honor to have been a part of a platform that has strived and been able to do that. Thank you to all the speakers, both national and international, for sharing such beneficial information and taking out time to increase the knowledge of so many at a time when the world was enduring such uncertainty. A special appreciation for Professor Samia for all her relentless efforts and constant guidance. She's our patron as well as our advisor for the academic team, and this series would not have been possible without her. Thank you, Dr. Sabah Akhtar, who's the co-founder of VFP and also the advisor of the academic team. She has truly been the backbone of our team. Whether it was 3 a.m. or 3 p.m., the door had always been open for anything either of us needed. And through all these months, what we have come out as is nothing less than family. And for that, I will remain eternally grateful to Professor Samia and Professor Sabah. Thank you, Dr. Rabil Tariq, who is also the co-founder of VFP, for her constant support, for believing in us and guiding us through every step. Thank you, Mr. Iftikhar Yazdani, CEO of Rahe Kamar and a partner of VFP. His company provides voluntary IT services for this Nobel cause. Thank you, sir, for your constant support, both technologically and emotionally behind the screen, making sure that all of us moderators were well looked after. Thank you, Mr. Daniel Shabib and Ms. Maha American for designing our graphics for the COVEB series. Thank you to all our team members and to all those who helped us on and off screen. Dr. Muhammad Ali Butt, Dr. Meher Zia, Dr. Zaid Hussain, Dr. Sahib Ansar, Dr. Tuba Saeed, Dr. Ibrahim Majid, Dr. Mohammad Pervez, Dr. Amna Pirzada, Dr. Fahad Athar, Dr. Pinar Farooq, Dr. Kadir Zafar, Dr. Mehreen, and everyone else part of the VFP family. And finally, thank you so much to all the participants for tuning in. These series would not have been possible without you. The details of our fundraiser will be up on our Facebook and YouTube page. We hope you help this Nobel cause. Once again, and for the last time, thank you on behalf of Team VFP, Team Yardim, and Team RMU. Allah Hafiz.
Allah Hafiz.